All right. So, welcome to day 2 of our VEFR education. Today, we are starting to jump into more like medically oriented things. We're not going to spend as much time talking about the history of EMS or anything like that, but we are going to be talking about the human body, the systems, and starting to understand some of that medical terminology we were mentioning yesterday. Now, before we do that, for those of you who may have not been here during our session yesterday, just want to review the house rules that I have for Zoom that just makes it a lot more enjoyable for me and for you as well. If you can, please have your cameras on so that I can see you're here, so I can see you grimace to my really stupid jokes. If you were here in the waiting room, you saw my intro slide with all the weird stuff going on, so you know that I like to make people smile. Also, if you have to eat or anything like that, you don't have to have your camera on 24/7, but it is nice to see the faces. Also, don't forget, if you have questions, don't be afraid to just put it in the chat. If for some reason I'm not seeing it, or if I'm not seeing you raise your hand or anything like that, just unmute yourself and say, hey, Kevin, I got a question, and it'll be all set. All right. Now, the first thing I wanted to do, like I promised, is I want to go over that lights page. I sent you that link yesterday. This is incredibly important if you want to receive your VEFR license, because this is how you'll actually go up and end up doing that through this portal. This is the Vermont State EMS portal, so every EMT in the state essentially has an account here, and this is where we manage our licenses. So once you've created an account, I just want to walk you through how you're going to go and like actually get into this class. So once you log in, this is the home page. This is just pulled off of mine. You'll go over to the Applications tab. Once you're in there, you're going to see something that looks like this, right? And you're going to head over to this box over here, the All Applications tab, and you're going to click on View All Personnel Applications. Now that's going to bring you to another page that looks like this. Now it's very important that you select the correct application. You are not selecting the one that says Initial VEFR. Okay, you'll do that later. What you need to do right now is click the Course Enrollment to Notification to EMS Office, and you'll hit Apply on that. Okay, that's going to just bring you to some questions. It's going to ask you to put in some personal information. This is essentially the state's application that checks to make sure you're a real human. It's not a full background check, but they will be just making sure that it's not like a bot essentially applying for licenses and things like that. So once you click it, start to fill out the information. You're going to select this VEFR box right here, and then down in your course number, this is our course number right here. So it's going to be ending in 228. That's the big one. Basically just select that in the drop down. You should see my name come up, and then basically how many slots are available. You'll just select that. Now, one thing you'll see in this next tab up here, after course number, you're going to see affiliations. Unless you are already on a ambulance service or fire department, you should not select that you are affiliated. That's going to essentially mess up the application. So just do not select you are affiliated. Just move on through until you get to the signature, and then once you've completed it, essentially what's going to happen is I'm going to see you on my roster in this this website. I'll see that you have applied for the course, and it's going to take like a week or so for the EMS office to just approve your application. So don't worry. If you are worried that for some reason it didn't work, just send me an email so I can look at the roster and verify that you actually got in. All right. But you might not see anything for a week or so. So just make sure you do that. I can get you the link in just one moment. Or if anybody else has it right now, that would be helpful too. But again, just select VEFR, put in that course number. I'll type it in chat right now for you just so you can have it. You can also find this website by just typing Vermont EMS Lights in Google, and it should come up. So here's the course number. And remember, do not select affiliations if you aren't affiliated. So Mia, this is required if you want to become a Vermont emergency first responder. It is completely up to you if you want to make this account. However, if for some reason at GIV in 2 weeks you realize, hey, actually I do kind of want to do that, it would be too late for you to really go ahead and do it. So I would like everybody to do this. If you don't follow through with it, that is totally fine. But in order to make sure everybody's in, there have been quite a few times where people in the Zoom sessions are like, I don't know if I really want to do this. And then when we're at GIV and we start doing the hands-on things, they change their mind, and it actually creates a little bit of an issue. So just go ahead and do it. And then if you don't follow through, that's totally fine. Yes, it should be the same account. I sent you the link at the end of the last session for the Lights website. So you don't have to do anything right now. I'm just walking you through how to go ahead and register for the course when we're done with this session. All right, any other questions before we jump into a little bit of Mentimeter? If you are 14, you can create an account. However, you probably won't be turning 16 within a year of completing this class. So you don't necessarily have to, but again, I would like everybody to do it just so I can have you all on the roster. Again, if you don't follow through, you don't want to be a VEFR, that is totally fine. All right. Any other questions? Okay, so here's the code and the QR code for Mentimeter. Just got a few things to do on here before we jump into our topics. Oops. All right, so go ahead and pop into the meeting. Can be on your phone, can be on a different browser or different page. Putting the code in the chat right now. And that's at menti.com. All right. So, just a question for you. I want to know, it's going to create like a word cloud. What's one thing that kind of stood out to you from yesterday? What do you remember from our introduction sessions? So people who are putting in the same word, the words will get bigger. So right now we got hearse and emergency and history as the biggest ones. Nice. Hippocrates, cool. Another history fanatic here. First ambulance was a hearse. Yeah, absolutely. Well, the hearse is standing out to a lot of people. That's usually how it goes. That's what stood out to me as well. Common injuries in Vermont, absolutely. Panic zone, for sure. Awesome. Emergency, CPR, ambulance. Cool. Thanks for humoring me with this. Now, just another question for you. Now that we've started to talk a little bit about VEFR more in depth, now that you know a little bit more about what it is, how ready are you for GIV? Did it make you more excited? Did it make you less excited? Just tell me to shut up and get to the fun stuff already. That's totally fine. Oh. Excited but nervous. Fighting for first with excited and ready. A few people are just nervous. That's totally fine. Well, looks like for the most part, most of you are ready. You're ready to get my mouth shut and start talking about other cool things, and you're nervous, but you're ready for GIV. So I too am excited. I'm getting very excited for the next couple weeks because I always have such a blast when we go up to Linden. Now, we'll come back to this again, but we're going to do some other things in our slideshow first. So this is actually a question for you guys. There are 3 things that we need to essentially have constantly working inside our body. It could be systems or structures that keep us alive. So if one of these structures gets damaged, blocked, or anything like that, that person is essentially in a really bad way. They're more likely to die. What do you think? Put it in the chat or call out. What are these systems I'm talking about? Brain. So people tend to say that. In my mind, I'm not thinking about the brain, because if we didn't have a brain, we just wouldn't exist in general. So heart. Yeah, that's one of the things I'm getting at. It's called our circulatory system or our cardiovascular system. So good job with that. Absolutely, the respiratory system is one of them. The lungs. Sawyer, you've got it. Airway, breathing, and circulation. So those are the three things we need. And how do we stay alive? It's actually pretty easy. You guys are doing a pretty good job right now. It's as easy as A, B, C. We need to have an airway so that we can get air and oxygen down into our lungs so that we can breathe. When we breathe, the oxygen goes into our blood, which is then circulated across our body to our heart, by our heart, sorry. And these three structures together, especially when we're talking about first aid or emergency, these three things together are the most important systems. So even doctors up at the emergency room, when somebody comes in with an emergency, what they're most concerned with fixing first are any issues with an airway, breathing, or a circulation problem. I always say you can't have a B without an A, and you can't have a C without a B. Because if somebody's choking, right, they swallowed something too big and it's stuck in their airway, no oxygen is getting down into their lungs, and no oxygen is getting into their blood, and their heart is eventually going to stop because of that, right? So it also goes the other way too. If somebody has lost a lot of blood or something is wrong with their heart, their breathing is going to stop and their airway is going to be moot, right? So this is what we all should be thinking about. You as a VEFR, this is where you live. We need to be able to recognize an issue with an airway, a breathing, or a circulation problem, because if we can do a quick fix with one of those issues, we will be able to essentially keep that person alive long enough to get them to the hospital, right? We can't do surgery in the field. We can do very little essentially to fix an issue, but what we can do is support it. Make that person essentially have more time so we can bring them up to the hospital where they can get that advanced life support, like a surgery, or getting prescribed medications, or maybe even things like physical therapy and stuff like that afterwards. So this is where we as EMTs and VEFRs, this is where we live. This is our bread and butter. We are going to get really good at assessing for airway, breathing, and circulation issues. And this is one of the ways that I started to think about anatomy. I remember being your age before I was an EMT, and my mom basically said to me, "Hey, I think you should go out and be an EMT. I think you would like it." And I said, "Mom, are you kidding me? Medicine's for smart people. Like, why would I do that?" And then I took an EMT class, and I was like, oh my God, it makes sense. And this is kind of one of the ways that I thought about it. And so if you think about a human body like a home, right? We all live inside our own bodies. It can make it a little bit easier in my mind to kind of expand it and look at things. So we've got a foundation that keeps us sturdy, that we don't necessarily fall over or we don't just crumple when the wind blows. And that's like our bones, right? It keeps us upright and sturdy. We have walls that keep the environment out, and that's our skin. We've got a central air system that helps cool and circulate oxygen, which is our lungs, and our airway, right, with those vents that we can get air in and out. We have pipes for hot water and cold water with our veins and arteries that is constantly circulating around our body. You know, if one of those pipes breaks, the house floods, there's structural damage, and it's not a good thing. So if we need to stop somebody from bleeding, that's kind of like the same thing. We've got filters, we've got pumps like with our heart, and we've got all the electrical wiring of our brain and our nerves. So this is kind of just how I like to think about a human body. Just makes it a little bit more simple for us, because when you start getting down into the really nitty-gritty of, you know, the proteins and the more complicated anatomy and physiology things, you start to get a little bit bogged down, especially at the VEFR level. So that's kind of what I want us to stay at, is we are VEFRs. We're going to be very simple when it comes to assessing, because we're more concerned with the big stuff. Pipes breaking, pumps breaking, no air or anything like that going in. Now, we do have to get into medical terminology because in order for you to effectively communicate with other medical providers, you do have to kind of understand where they're coming from and what they are saying. And like I was talking about yesterday, no matter where you go in the world, if you learn medicine, they are going to teach you the medical terminology. And it's essentially a new language in a way, where you're going to learn how to recognize what different words mean based off of the different parts of it. And you could communicate with anybody across the world. If you say medical terminology terms and they are also a medical provider, they will know what you're talking about. And in order to do medical terminology, in order to understand it, we have to look at something called etymology, which is essentially the origin of words and how it was created, the development of its meaning. And you might actually be surprised how much medical terminology you know already. But let's break down etymology a little bit and get to like the bigger point of what I'm talking about. So, what better word to describe etymology than etymology itself? So, this is another one of those things that goes back into history. Pretty much, yeah, Alexis, taking Latin purely for this reason, 100%. I took Latin in college, and I also took like a course called Medical Terminology with roots in ancient Latin and Greek. And that's exactly what it is. It's essentially just an English, amalgamation of these two old languages. So we go way back to like ancient Greece, where they've got the word etmos, which means true or real or actual, and then logia, which means the study of. So they created the word etymologia, which means the study of a word to find out its origin. That's way back in ancient Greece too. They thought about this as well. Now, that word, through time, got picked up by Latin, right? As the world changed, it became a little bit different, pretty much the same, meaning the same thing. Now we go into Old French, where English comes from, and we've got a little bit different, but it really sounds and relatively looks the same, up to Middle English, and now up to here, right? To where we say it as etymology today. So that's kind of how we bridge the gap between the ancient world and the language, and then modern day with medical terminology. So whenever we see a medical term, this is exactly what we're going to try to do. We're going to try to look at the different parts of the word to figure out what it means. For example, right? All the medical terms that you're going to see are going to have what we call a prefix, a root, and a suffix. Now that sounds like a bunch of grammar stuff, and it is, but it's a little bit simpler than you might think, because a lot of these just continually show up, and once you recognize a few, you're going to be able to put them together. So, the word hypo. This means low. And sugar, we would call glycemia, right? So, hypoglycemia means low blood sugar. Hyper, you actually might know this already, right? If you describe somebody as hyper, you would consider them to be like amplified. They have a lot of energy, right? They might be high on that energy scale, excessive, right? So hyper means high. And volume, like volume, means blood volume. So if we put that together, hypervolemia, that means high blood pressure. Now, the next one, Brady, means slow, not Tom, all right? And then pnea means breathing or air. So if we have slow breathing, bradypnea, that means that somebody is not breathing well enough. Or if we've got the word tachy, that means fast, and cardia means heart, right? Just like the cardiovascular system, card is that term for heart. So if we've got fast heart, that means like a fast pulse. The pulse is too fast. Now, the ia at the end here, that's just an add-on that basically means a condition. So that's how we get a condition of low blood sugar, a condition of high blood pressure. Pnea doesn't have one of those. It's just the A at the end, meaning breathing, right? And then cardia, again, it's a condition of a fast heart. So this is how all medical terminology works. And if we start putting them together, we get those words, right? Hypervolemia, hypoglycemia, bradypnea, tachycardia. But we can also cut them in half and start to rearrange them into things like hyperglycemia, right? High blood sugar, or tachypnea, fast breathing, or hypovolemia, low blood pressure, hypoperfusion, low circulation, bradycardia, slow heart rate, right? So that's how medical terms work. And now this is just a short list of some of the more common prefixes in medicine. And I've highlighted some of the ones that you might actually recognize. You might be surprised, but English, the language that I'm speaking right now, is essentially an amalgamation. It's really just a clamping together of quite a few different languages, including Latin and Greek and French and other things like that. So, we've got ante, right? If you've ever heard about poker, right? You ante up before you play, and that means before, right? Bi, if we're talking about a bicycle, right? That means two or double, right? And chemo means a chemical, like chemotherapy. Let's see, hyper we talked about. If we're talking about like international, right? Inter means between. So that means you're going in between two countries. Neurological, nerves, all that kind of stuff. Post as in after, right? Post-op. So you actually probably know quite a bit of these already. And then here are some more suffixes that you might already know as well. Right? So like mortem, meaning death. Post-mortem, after death. Opsy, like autopsy or something like that. It's a display of. Edema, swelling we'll be talking about. Dilation, to expand, to extract, to stretch, things like that. So it might seem kind of overwhelming where I tell you, hey, guess what? You need to learn a new language in order to be a VEFR. Now, I'm not talking about being fluent or anything like that, but there are going to be some of these terms that are really going to benefit you to essentially recognize and then be able to understand what that person is talking about. So if you're working with another medical provider and they say they have hypoglycemia, you don't want to sit there and be like, ooh, what does that mean again? Right? It's one of those very common ones where if you know that it means low blood sugar. And that understanding of medical terminology brings us to this other idea of essentially pathophysiology, which means understanding why something is going wrong and what systems are being affected by that. So when it comes down to it, there is a large range of in-depth learning that you could have, right? You could talk about the proteins and ATP and development in the cells and the all those different things. But for us as VEFRs, we need to get essentially to a basic understanding, because we don't need to know what's going on necessarily in the cells themselves, but we do want to know what system we are worried about with this person. So a basic understanding might be something like this. If we are treating a patient who has diabetes with low blood sugar or something along those lines, that would be a pancreas issue, because when it comes down to it, like the blood sugar is tied to the pancreas along with insulin. So we know that if somebody has diabetes, there's something going on with their pancreas, that it's not excreting enough insulin, and we know that they need some blood sugar. If we're talking about a stroke, right, we know that is a brain issue. Somebody can only have a stroke if there's a blockage or bleeding inside their brain. And then on the other side, a heart, right? Myocardial infarction. This is just the fancy medical term for a heart attack. So we know that it's a heart issue of vessels being blocked inside that heart. And then asthma, right? That would be a lung issue, because those bronchi in the lungs are getting constricted. It's making somebody wheeze. They're not being able to breathe as much. So we would know that, hey, okay, they're having a lung issue, which means I have a medication called albuterol that actually fixes the problem or helps with the problem. So this is what I'm hoping that we can get at by the end of our online sessions and then our in-person sessions as well. Just having this basic understanding of where the issues that we're assessing for come from. Right? What system of the body, what organ is being affected? Now, the other thing we need to know about is how we can describe where things are on the human body, and then also just recognizing what a normal, uninjured human looks like. And we do that by assessing somebody's anatomical position. Right? And I have another one of these history examples here. Leonardo da Vinci, in the 1400s in Italy, right? He created the Vitruvian Man, which was all about the symmetry of the human body. And that's really what we look at. Now, you can tell me which one has better art, the one made 2-3 years ago or the one made a couple hundred years ago. That's up to you to decide. I think I know which one looks better, but essentially it's the same thing that we're worried about here. It's really easy for us if we're assessing a patient in anatomical position. We lay them on their back with their arms out to the side a little bit. It's going to be very easy for us to essentially look at their body and say, okay, that looks wrong. If it is not symmetrical, if we see injuries, if we see ways that they're laying or things like that, that is going to play a huge part in our assessment. Now, along with that, the anatomical position, we also have to understand and agree upon essentially some different deviations of how we can start to, describe where things are. It's not as simple as it might seem to describe where an injury is, because we do need to be a little bit specific when it comes to medicine, right? If I said he has an injury on his left arm, a medical provider will say, where on his left arm? And if you're like, oh, well, a little bit lower, like low arm, that's not enough for us, right? So this is how we start to describe it. We've got terms called anterior, before, right, ante, and posterior, after. So our anterior is our front side, because it comes before, right? And then our posterior is our back side, because it comes after. So if I was going to describe somebody laying on the ground when I showed up, I might say, I found them laying on their anterior. They were laying prone, right? Face down, not good. After that, we've got this idea of something called proximal and distal. So that's essentially what we use for arms and legs, extremities. When I say proximal, it means closer to the core, closer to the chest, and distal means further away, right? So let's say I'm going back to that first example. He is injured on his left arm, distal to the elbow, which would mean that he has an injury below the elbow. Or if he has an injury up high, I could say proximal to the elbow, meaning higher up, closer to the body. So if you're trying to describe where an injury is to another medical provider, that's one of the best ways to do it. Now, when we get into the core, we have another term for like further away and closer, and that's going to be medial and lateral. So if we imagine that we essentially split somebody directly down the middle, they should be pretty much symmetrical, right? This is called the medial line, going straight through. So anything closer to that midline would be medial, and anything out to the side would be lateral, right? If you've ever played rugby or football and you throw a lateral pass, that means you're throwing it to the side instead of forward. So a lateral issue would be further out to the side, where a medial issue would be closer to that core. Now, we also have this another line. If we split ourselves directly down like through the nose, we also can split the human body to the side, and we call that mid-axillary. So as if there was a line coming down through this way. Right? We also have that midline, right, directly down the middle. And then there's one more line that's not on this graph here, but essentially this is the medial line right down the middle. And then if we were to go and divide this side in half again, right there, right through the midline of the clavicle, that would be the mid-clavicular line. These are going to be important if you start learning how to do EKGs and things like that, because we use the mid-clavicular line, we use the mid-axillary line as really good landmarks for us when we're applying those patches. And then you might see these down here and be like, that doesn't look like medical terms, left and right. Well, the challenge with using left and right in medicine is that it's no longer about your left and right. It is all about the patient's. And we're most of the time looking straight on at the patient. So it's really going to be flipped in our head. You can, if you're starting to describe, hey, they have an injury on their left side, and it's your left side, but really their right, you are giving wrong information, right? So you have to start using that left and right in the idea of the patient's left and right, not yours, All right. This does take some practice. I'm not expecting you to have it down like right now, but this is one of those things that you do want to start getting familiar with so that you know how to describe where injuries are and that you can use these landmarks when you're doing assessments. We also have to be aware of body positions for multiple different reasons. There are some treatments that we're going to do, things that could really help people out just by changing their body position. If we're looking at prone is actually a very severe situation if somebody is in like a bad way. If they have a medical or traumatic accident and they're laying prone, this blocks one of those ABCs we were talking about. Does anyone know what this one blocks, why this is a life threat? Yep, the airway, right? The airway and the breathing. Because if somebody is unconscious and they're laying on their face, they're not able to essentially do what you can do when you lay down when you're conscious. Like if I lay down on my face right now, I would be able to recognize when I couldn't breathe and I could turn my head or something like that. I could make sure that I'm not going to suffocate. But if somebody is injured or they're unconscious or they're really sick and they're laying prone, this could be enough where it's pushing on their face and it's blocking their airway. So a really quick treatment we can do is just roll somebody to supine, roll them onto their back so their airway isn't blocked. And when someone's laying on their back, that's actually putting them in what we call that anatomical position. So it makes it a lot easier for us to essentially assess their body, assess if they have injuries or if they're having difficulty breathing by putting them on their back into that supine position. Now these next two down here, the right lateral and left lateral recumbent, this is what we would call the recovery position, right? If somebody is really drunk and we're worried that they're going to vomit, we should roll them onto their side like this, right? Because if somebody's laying on their back or on their face and they're passed out and they throw up, that vomit's either going to go right down on the floor in front of them and they're going to breathe that in, or they're laying on their back and it's going to go straight up and straight down and block their airway. But if we roll somebody on their side, if for some reason they vomit, it's going to come out the side and not go back down their throat, which could be really dangerous. So anytime somebody's kind of like unconscious or too drunk or something like that, we try to roll them onto their side just in case. Now, Fowler's, this is kind of how we would transport somebody in an ambulance. This is just the normal body position that somebody has when you're sitting on a stretcher, right? Legs straight out with the back up. It's just the more comfortable position. We don't really have like seats for somebody to sit in the back of the ambulance, but we do have that stretcher. So this is more how we transport somebody. And then I do just like to show Trendelenburg because this is one of those times where we used to use this position a lot. This used to be like one of our go-to body positions if somebody was really sick, because the goal here is that when somebody is in a bad way, their body needs more blood in the core. So it starts to like shunt blood away from the arms and the legs to the core. And so the idea here was that we use gravity to start draining some of the blood from the legs back into the core to make it a little bit easier. However, through medical studies, we found that it wasn't working because the body wants to maintain equilibrium. It wants to stay the same. So when you start adding that elevation, the body doesn't, it doesn't have any work relieved. It actually starts to work harder trying to push the blood up the legs. So we used to use this one a lot, but then after those medical studies showed it that it wasn't working, we now just transport people who are really sick in this supine position. So we don't really use Trendelenburg anymore. But again, this is mainly so that you can understand how we're going to transport people, how we're going to assess them, and then, what we call those positions so that if you're documenting something, you can say, okay, found the patient in a prone position, rolled them into supine, and then transported them Fowler's, right? That's just going to help describe to a medical personnel what was going on. Okay, now we're getting into some of like the anatomy and physiology breakdowns of the human body systems. So the first one that you see on every single person that you have engaged with is their skin, their integumentary system. It's one of those hard words to say. But this is the largest organ that a human possesses. We consider the skin to be an organ. It is the largest one that we have. It's also a very easy way to assess if somebody is sick. And we'll get to that in a little bit. But essentially, the skin does some very important things. It does protect us from the environment to a point, right? We're not like an armadillo. We don't have external armor. We are pretty soft and fleshy, but for the most part, right, you're not getting damage just by existing. Our skin provides some protection. It also is the connection between the outside world and our brain. Our brain only knows what's going on because we have nerves essentially in our skin. So that's how we tell temperature. That's why you guys in Vermont are feeling so sweaty right now, because it's hot and it's humid and your skin is recognizing that. And it's telling your brain, oh boy, it's hot, right? Start producing some sweat. That's why it works. So it transmits that sensory information from the environment to the brain. It's also how we feel things, right? If you touch something, you are feeling it through your skin, right? The nerves and nerve endings in your skin, that's how it's sending the signals up to your brain. And so that's how we know what's going on. If we didn't have skin, we wouldn't be able to feel anything, right? It could be bad. Now, again, I said it's the largest organ in the entire body, and it's made up of 3 different layers. Right? First, the one that you look at and see is the epidermis. Right? That's what everyone presents to each other, is what we call the epidermis. And the epi means above or through, so on top, essentially. That's what we see is the epidermis. It's one of the thinner layers of our skin. Most of like the sponginess and stuff that we have, that comes from what we call the dermis, which is the larger layer underneath that. It's like our inner skin, right? This is where a lot of our blood vessels and our nerves and our pores and our hair follicles and stuff are, and that's where they come through and then poke through the epidermis. And then under that, we have something called the subcutaneous tissue, or the hypodermis. Subcutaneous is a little bit more common in what we say. And that is just essentially a layer of fat underneath our dermis and on top of our muscles. That layer of fat protects the muscles from the skin, and it also insulates us. It helps keep us warm, right? So if it's winter time, you do actually want a little bit of fat on your body, or else you're going to get extra cold. And that's what it does. It insulates us, and it creates like a layer between our muscles and our skin. This is going to be really important if we start talking about burns, because if you've heard the term like 1st degree, 2nd degree, or 3rd degree burn, we are directly relating that to what layer of skin is affected. So if somebody has what we call a 1st degree burn, it is affecting the first layer of skin, the epidermis. If they have a 2nd degree, it goes down into the dermis. And if they have a 3rd degree, the burn gets down into that subcutaneous tissue or even further, right? So that's why it's important to understand the layers, because there are going to be some injuries like burns and frostbite that relate directly to those layers of skin. Now, underneath all that skin and muscle, we have our skeletal system. This is our foundation, right? We could have muscles and we could have skin, but if we didn't have bones, we would just kind of be like this puddle on the floor, right? So this gives us support. It protects our vital organs. So your rib cage, right? You got that stuff underneath your chest right here because your most important organs, like your heart and your lungs, are underneath it. It's protecting us, right? It's not as good as like an armadillo or like a tortoise or something with their external shell, but we do have this support, and it does protect us. Now, it usually consists of around 206 bones. There are some people who are born with like a few more in just interesting places, like if somebody has extra toes or extra fingers, and then there are some people who have less. I met a guy who had no femur in his right side after it got broken and he had surgery. And so he had 205 bones when we were on the ambulance. But for the most part, it also acts as that framework. Again, if we had muscles and we had bones, but the muscles weren't connected to the bones, we wouldn't be able to move, right? We wouldn't be able to do anything because the muscles go connect to those bones and allows us to have that structure. No, he couldn't still stand. He was in a wheelchair. So that's why, we would see him pretty frequently on the ambulance. He was a kind of cool dude, but he'd call the 911 quite frequently because he had other medical issues as well. So we got on pretty good terms. And it allows for the motion in the body. And of course, skeletons are kind of spooky, right? Pretty much every culture in the world, in the history, uses bones in a way of like, ooh, this is creepy, right? If you look around on Halloween, you will see plenty of skeletons, and we always associate it with a little bit of spookiness, right? Although if I saw a skeleton breaking down those dance moves, I don't know if I would be that scared. Now, in our skeletal system, there are some bones that are more important than others. Honestly, when it comes to like emergency medicine, I'm not really that concerned if someone has just a broken arm, right? It's very rare and pretty much impossible, unless there's some really outside extraneous circumstances, that a singular broken bone will end up killing somebody. However, the bones that protect our spinal column, right, our spinal cord, these are really important, because if one of those was broken, it could be a damage to the spinal cord, and that could lead to some really severe issues. Specifically, when we're talking about what we call the cervical spine, our neck, right? This is the most important part of our spine, because under here is where our brain essentially stores the processes that we don't want to think about. So where we breathe, where it controls our heart rate, is in that cervical spine, right? If we had to think about like breathing, or if we had to think about beating our heart, life would be really annoying, right? You'd be sitting there. All we could do is like, okay, beat my heart, breathe. Okay, beat again, breathe. That's what we would have to do. We'd have to constantly focus on it. So our body essentially takes that out of our control, puts it into this cervical spine, and allows us not to have to think about it. But that means if that area is damaged, that person's ability to breathe or beat their own heart might not be intact. So that's why we consider this to be the most important thing, right? We have a saying in EMS that cervical 3, 4, and 5 keep us alive. So the third, the fourth, and the fifth vertebrae in our neck are that most important section of our spinal cord. Now, there are quite a few vertebrae throughout our entire back, and so the tip that I have for remembering how many vertebrae are in our back is this. We have 7 in our cervical spine. And if you wake up early like me, you probably have breakfast at around 7. Now we have 12 in our thoracic spine, in our back. And usually eat lunch around 12. That seems like a good lunchtime to me. Now the lumbar, that's at 5. I like to eat dinner a little early, so I have dinner at 5. I'm also a sweet tooth, so I like to have dessert at 5 as well, right after my dinner. And then sometimes I wake up in the middle of the night, 3 a.m., and have a late night snack down at the coccyx. So we have 7 in our cervical spine, 12 in our thoracic, 5 in our lumbar, 5 in our sacrum, and 3 in our coccyx. But again, cervical spine is what you're most concerned with, right? Having any sort of spinal injury in like the thoracic or lumbar, that's not good, right? But we're more likely to see somebody get really close to death if they have a break in their cervical spine. That's just the most important part for us. So a lot of what we're going to do at GIV is we're going to practice holding somebody's C-spine in place, making sure it doesn't move, and then also applying like the cervical collars, which protect if somebody might have like a small injury, or if they have a big injury, it's going to protect it from getting worse. Now, so attached to all of our bones, we have muscles. Now, there's also quite a few different types, and again, we have this deviation between the stuff that we do consciously, the things that you think about and make happen in your body, versus what your body does on its own. So that skeletal muscle is a voluntary version of the muscle. It's connected to our skeleton and allows for movement. So when I think about doing this, I am able to do it, right? I'm not really like spending a lot of time telling my brain, hey, move my arm. I'm just doing it. It's natural for me, but I get to control it, right? My body's not doing this on its own. I am telling it to do it. Whereas things like our heart, right? The cardiac muscle will be involuntary, because you don't want to have to think about beating your heart every single moment of every single day. It's going to do it on its own. And it has its own electrical system, which we'll talk about in a little bit when we start breaking down into the cardiac system. It keeps itself going. It is its own routine. It is doing its own self. We don't have to think about it, right? We can't even really do that much. You can try to slow your heart down if it's beating too fast by taking nice deep breaths, but you are not like consciously being like, okay, heart, slow down, right? You are providing more oxygen to it so it doesn't have to work as hard. That's kind of why we do it. And then on the other end of stuff that you don't want to have to think about is like digestion, right? If every piece of food you ate and you were like, okay, it's in my stomach, breaking it down, now moving it to my small intestine and then into my large, okay, got to go to the bathroom now, that would not be a fun existence, right? We would be constantly worrying about beating our heart, breathing, and excreting, and we don't want to have to do that. So the muscles, like inside our digestive system, your like stomach and your intestines, things like that, that is all involuntary as well. Also, like what we would call our diaphragm too. Like your diaphragm moves when you breathe. You don't necessarily control it all the time unless you are actively trying to breathe. The other things about these muscles is that skeletal muscle can heal itself, whereas cardiac muscle can't, right? If you exercise and you work out and you felt that like burning in your muscles, that lactic acid getting sore, right? That's actually micro tears in your muscle. You're actually damaging your muscle a little bit so that it heals back stronger. That's kind of the whole point. That pain, that soreness means that you've damaged your muscles very little bit, and now your muscles have to grow back stronger. They knit itself, and that's why they get bigger and more firm. But if the heart, the cardiac muscle, starts to have injury or suffer, it can't heal itself. That's why heart attacks are such a big deal, because if somebody is not getting oxygen to their heart, that heart tissue is dying, and it's only going to stay dead. You can't regenerate that cardiac tissue. So that's one of those things that makes muscles so important for us to understand. There are some things that we do voluntarily and some things that we don't. Now, bringing it all together for our physical muscles and feelings and skin, we have our nervous system. So this massive expanse and highway of these nerves that go throughout our body, which essentially communicate the sensations between our internal organs and our brain and our extremities in the outside world in our brain. We kind of divvy it up into two different sections. We have what we call the central nervous system, which is the brain and the spinal cord. That's really big. Essentially, you can see right here, that's what the spinal cord looks like, and I'll show you another picture again. But this is the nervous system. So we have lots of these going throughout our body, which provide us that sensation. So the more important one, the central one, that controls a lot of things, is our central nervous system and our spinal cord. And then our peripheral nervous system is all the highways of the nerves that go out into our extremities, which then allow us to feel. So if I clap my hands, I feel that sensation through my peripheral nervous system, and it goes up into my central nervous system, right? Up into my brain where it understands what's happening. It happens in like a fraction of a second, but that's why you feel. It's because those nerves transmit that sensation up to your brain, and then your brain comprehends it in a flash, and it's really kind of interesting. Now, I always think it's funny, but that's what you look like. That's you, right there. That's a selfie. Okay, that's what I look like too. Underneath all that skin and like bone and hair and makeup and stuff, that's what you look like. Here's some more. All right, that's the spinal cord. That is like right up at the brain. You can see the bottom of the brain right there. That's how thick it is, and you can see all of the different passageways of those veins and then those nerves going out, and that's what we look like underneath everything. That's where all of our sensation comes from, and I think that's really interesting, and that's what we're trying to protect, especially up here, right? If this is damaged, this is where all the chemical and electrical signals that keep us breathing, keep our heart beating, that's where it all comes from. So if any of that nerve tissue is damaged, a person's going to be in a lot of pain, and it could really disrupt their just general life. Now, inside the nervous system, we have that central and peripheral nervous system, but we also have what we call like this sympathetic and parasympathetic responses. This is natural, like human processes when we start to experience something. So a sympathetic nervous system response is an agitation. It is an excitation. This is when you get scared, right? This is when you have an adrenaline rush. Your central nervous system releases adrenaline and you get agitated. You start to go into that what we call fight or flight. And so this is all stuff that keeps us elevated. So we say the 4 F's of sympathetic nervous system response are flight, fight, food, and mating, right? That's all the stuff that gets people agitated and going, okay? Epinephrine and norepinephrine are released, neurotransmitters, these chemicals. It's adrenaline, essentially. It makes your blood vessels get smaller. It opens up your lungs. It increases your blood pressure. It prepares your body to either run for a long time or fight, right? It gets you agitated. And we hear things like stories of moms like lifting cars off kids because they get that spike of adrenaline and they're actually a lot stronger in that moment than they think. And that's what the body is supposed to do. It's supposed to give you this burst of energy so that you can either run away from an issue or fight an issue, right? So our heart rate increases, our breathing rate increases, and our blood pressure goes up. We're getting ready to do something. So if you have a sympathetic nervous system response, you probably look like this guy. Now, on the other end of this, we have the opposite. We have what we call a parasympathetic nervous system response. This is when after we've done like a sympathetic response, we've been active and agitated, our body can only do that for so long, right? It can only stay extra elevated for so long before we run out of energy and we need to take a break. So this is what we call like the rest and digest, right? If you got really scared and you ran for a while and you got home, you're probably gonna be like, oh man, I'm tired and I'm hungry. You sit down, you kind of feel sleepy, you eat something, and then you fall asleep. That's what the body is doing. It's trying to reverse what it did before, and it's trying to get you back to normal. So it actually inhibits the body from overworking. You get sleepy, you get tired. It tells you to take a break, tells you to rest. And your body as it attempts to return to a calm state, it slows your blood, it slows your heart rate, it lowers your blood pressure, and it turns your breathing back to normal. So if you ever run for like a long distance or you got scared, right, afterwards you might actually feel kind of tired because you burned a lot of extra energy doing that sympathetic nervous system response. So on the other side, you might look like this, right? Chilling, resting, and digesting. Does anyone have any questions about the nervous system, bones, or anything like that? Cool. You'll notice throughout these days that I ask questions of you, if you have any questions, just so I can take a drink of water. So it's okay. Hydrate or dihydrate? Oh, what bones are the most fragile? It really depends. There are more bones that are like more commonly broken. So arms and like what we call our radius and our ulna, our humerus, ribs are pretty fragile sometimes. Clavicles, honestly, are probably one of the more easily broken bones just because they're just right up here and they're a little bit thinner. But it's also going to depend on like the person, because the older you get, if you have a condition like osteoporosis or something like that, your bones just get a little bit more fragile as you get older. I'd say the more commonly broken things are like lower legs, tib fibs, like your shin, the radius and the ulna and the clavicle, fingers and toes, stuff like that. The most strong bone we have is our femur underneath your thigh. That's the biggest bone we have. It's also the strongest. It has to essentially support us every time we walk and do anything. So that's probably the strongest bone we have. Outside of that, they're all about the same. Good question, though. All right, so now we're on to that breathing system, the respiratory system. Now, we split this up into two different sections. We call the upper airway and the lower airway. Now, the upper airway, this is a little bit easier for us to understand because we can actually kind of see it, right? If somebody opens their mouth, you can look inside their mouth and you can see those structures. You can see their nose, you know that you can look inside and assess those structures. Whereas the lower airway dips below into our chest and we can't really see somebody's lungs, right? We can't see their bronchi without an X-ray machine or anything like that. And we don't have X-ray vision, so we have to kind of more imagine what's going on in the lower airway versus the upper airway. And it's really important for us as EMTs to know, and VEFRs, because we are going to be looking inside the upper airway for potential obstructions, right? And as an EMT, we can put stuff in. I'm going to show you a video later. But it's important for you guys because we're going to talk about airway positioning and how we can open somebody's airway if they're not breathing, either by just tilting their head or by doing something called a jaw thrust. We might be like suctioning out fluids or blood or vomit inside someone's mouth as well. And so we need to look inside and see what's going on. We need to look and see if there's any obstructions, right? Did somebody like swallow something that we can still see? And if somebody is like, if they have, if they're sick and they have a cough, right? We want to be able to determine, does it sound like croup or could it be potentially epiglottitis, all those kind of stuff. And so upper airway knowledge is really important because that's part of the three big things that we have to worry about: the airway, the breathing, the circulation. We have to understand the structures in the airway. And so here's a picture of a real cadaver so you can see what the structures look like. So these are the ones you should really start to get down in your knowledge of the upper airway. So of course we've got our nose, our nasal passage, which goes through our sinuses and then connects down into our airway. We've got our oral passage, right, where you're hearing my voice coming from and where we breathe and where our tongue is. Now the tongue is one of the most common airway obstructions. If somebody is sick or really injured and they've lost some like muscle tone in their mouth, they might be snoring. And that's evidence that the tongue is kind of flopped back towards the back of the mouth and it's obstructing their ability to breathe a little bit. So just doing a head tilt chin lift or a jaw thrust could help cure that. After our tongue, we've got what we call the pharynx, which is the back of the throat, right? If you're looking in somebody's mouth and you look directly at the back before you see it start to drop off, that's what we call the pharynx. Now the epiglottis, this is a little flap that we have in our airway that differentiates and creates a barrier between where the air goes down and where food goes down, right? So whenever you swallow, like that, if you're swallowing food or you're swallowing water, your epiglottis goes over your trachea so that you don't accidentally like get liquid or solids down into your airway, right? That's what would happen when somebody's choking. And it's like a human rite of passage for you to essentially, like almost choke, right? If you've ever been eating some food or things like that, and you get that kind of that's your epiglottis essentially not keeping up, and you're like almost get it into your airway when it actually is supposed to go down your esophagus. Now your larynx, this is your voice box, right? This is a little bit further down, but this is where those vocal cords are, and that's where you start to learn how to speak, and you get to, when you learn your language, you start to be able to change how they move. That's how we make sounds and things like that. Our esophagus, this is the tube which food and liquid goes down into our stomach. It's not like a solid tube. It's more of, the trachea is like rigid and is made up of cartilage, whereas the esophagus is more like a blood vessel that's kind of limp. And when you swallow, it kind of just like pushes stuff down, versus the trachea that needs to be open all the time for us to get air in. And you can feel your trachea. It's right at the front of your throat. You can feel that solid kind of part of your airway where your Adam's apple is, because that's where we need air to go down into our lungs. It needs to be a solid structure. But that also means it can be damaged, right? It could be broken or something along those lines. So these are the biggest structures that you guys should just have in mind and know about the upper airway. All right, so now the stuff that we can't see, that lower airway. This is all about our lungs. The trachea is going to be part of it because the trachea goes down deep and then splits out into our lungs here. But the main things are, our lungs are held in place by our trachea, by some veins and arteries that weave through and interconnect with that tissue. And then also some what we call pulmonary ligaments, which are like, similar to muscles and tendons and things like that kind of keep them in their normal position. If we're looking at our lungs too, again, for the most part, we're symmetrical. However, we do have some systems that only have one thing, and our lungs aren't entirely symmetrical. Our right lung has 3 different lobes. It's got the upper, mid, and lower lobe, where our left only has 2. Does anyone know why our left only has 2 lobes instead of 3? Yeah, Zoe, the heart. The heart sits right there. And so if the heart, or if the left lung had 3 lobes, when we took a deep breath, one of those lobes would probably expand and press on the heart. So we have developed just only having 2 lobes on that one side, and our heart sits right in between here. Right between those lungs, a little off to the left, and it's nestled underneath those lungs. So if we had that extra lobe, it would actually be a barrier. Now, the big structures that you need to know are the trachea, because it's that solid cartilage going down. It will then split into two sides at what we call the carina. It goes into the lungs, and it really branches out. Like if you flipped this picture upside down, it would kind of look like a tree, right? Those bronchi, those tiny little solid tubes we've got right here that branch off from the trachea. That's what is actually bringing the air that you breathe down into the lower lobes of your lungs. So if you take a deep breath right now, you are taking air through your mouth into your trachea, down into your bronchi, which then inflates our lungs, and the oxygen there gets pulled out into our blood. So the bronchi themselves are solid structures, little tiny airways, and then at the base of them we have what we call alveoli, which are essentially little tiny, like little bunches of grapes. That's what they kind of look like, but they're more like little balloons. So when you take a deep breath, they expand. That's what is happening when you take a deep breath, and there's millions of them in your lungs. And that's where that gas exchange happens. That's where the oxygen goes into your blood, and the carbon dioxide comes out of your blood, and that's what you breathe out. So that's where the most important structures, right? And if somebody has asthma, their bronchi are getting swollen, right? So if you've ever heard somebody wheeze, or if you've wheezed yourself, like a, right? That's me forcing it, but that's when the bronchi get small and it's making a whistling sound, and air can get trapped in or not come out as easily, and that's what you're assessing. So if you see somebody who's wheezing, you know that their bronchi are a little bit constricted. And then other diseases like COPD with like emphysema, if somebody's been smoking their entire life, that affects the alveoli. And those bunches of grapes, they're supposed to be elastic and they're supposed to be stretchy, and they start to get not stretchy and they start to be floppy, and it makes it hard for somebody to continue to breathe. So those are some of those big structures when we're talking about the lungs that really matter. And here's how it's supposed to look. There's just a pair of lungs inflating. So whenever you take a deep breath, that's what's happening inside your body. Now this is like attached to a pump, so they probably won't inflate like to that level, but it's just showing you how small they can get into how big they are. They're essentially just like flesh balloons inside of our chest. Any questions so far? Thank you to the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 out of 61 of you with your cameras on. It's nice to see your faces and smile. You guys are my favorite so far. No pressure. Now, the diaphragm, this is a muscle that helps us breathe. It's called the diaphragm, not the diaphragm as it's spelled, as at least you want to say. It is a dome-shaped muscle. So if you're unsure what that means, here's a list of famous domes. But essentially, it's just like that, right? It's kind of rounded. And it sits underneath our lungs, underneath our rib cage, and it helps us expand our lungs. So when you take a deep breath in, your diaphragm moves down, like in this GIF right here. It moves down to allow our room for our lungs to expand, to allow air in, and then when we exhale, it moves back up and helps push those lungs into a smaller location, helping us breathe out. Yeah, Jarrett, what's your question?
So isn't the diaphragm also what kind of pulls on the lungs to make it so you can breathe?
So yeah, it's not actually like pulling on the structures of the lungs themselves, but it moves down and it makes the chest have more area, right? It allows your lungs to have room to expand. So it's not like the muscle is, tugging on the lungs. It's really just kind of like a plug, right? It sits up against them, and when we take a deep breath in, it moves down to allow space for them to expand. So yeah. And so one of the things too about this is it's not just, having that drive. Oh, my light turned off. That's not good. I charged it. Hold on. Sorry, guys. Well, I might look a little wonky for the rest of this if it goes off again, but okay. Here, let's try this. Technological issues, bane of my existence. Well, you don't need to see me, you just need to hear me. I'll just be kind of spooky. Ooh. So the diaphragm, it moves down, and if the diaphragm is injured, right, that's going to lead somebody to have trouble breathing, because if that muscle is damaged or if it's not working, right, it's not actually going to allow somebody the ability to breathe. This is honestly why people who overdose on opiates end up dying, is because opiates are really good at essentially slowing body processes. And we're going to talk about that more tomorrow, but really why people die from opiate overdoses is that their diaphragm just stops moving. Their brain stops sending signals to that muscle to expand and contract to allow air in and out. Now, when we've got that air coming into our lungs, this is kind of what happens, right? So if you take a deep breath right now, you just breathed in roughly 20% oxygen, 21% oxygen. You really breathed in like 80% nitrogen gas, and then 0.4 or 0.04% of carbon dioxide. So the air that we breathe isn't like 100% oxygen. It's really only about 20. And we take in that oxygen. It goes down into those alveoli. Here's that picture of like those little bunches of grapes in our lungs. And they expand. They're in that shape of like all those little tiny balls because that increases surface area. There is more area for oxygen to bind onto. So whenever you take a deep breath, the oxygen goes into here, and then the blood vessels that are connected to our alveoli, they extract the oxygen, they put it into our blood, and they also put out waste stuff. So when we breathe out, right, we breathe out less oxygen, more carbon dioxide, because whenever we use oxygen in our body, carbon dioxide is the byproduct of it. It's like what happens when we use it, when we burn oxygen. And so we're getting rid of this waste and we're taking in more oxygen. So at the EMT level, we start to be able to essentially give people oxygen and recognize that, hey, that 21% of like room air of normal oxygen is not enough. And so they need more, which is why we're going to give them like 100% pure oxygen through a mask or something like that. We need to essentially give them more oxygen so that their body can function. And here's a really cool image of all the bronchi. This is just like I'm not sure if it's real, but it might be like a cast of somebody's lungs. And this is how many little bronchi are in there. And so you can see those little tiny structures that bring the air to the little, far reaches of our lungs. And all of those little structures are really important. And if they're blocked, if they're damaged, if they're constricted, we hear that wheezing, and that person has a lot of difficulty breathing. So this is one of those things that I really want to get across to you. We have to start thinking about breathing in two different ways. There is a mechanical part of it, right? There is a very rigid thing that needs to happen, which is getting air physically into the lungs, right? The act of being able to ventilate, a mechanical thing, versus the respiration, where that chemical actually happens, where the chemical exchange happens. Now, there can be a couple different reasons why somebody has difficulty breathing. It could be a mechanical issue, where they aren't physically able to get air in, or it could be a respiration or a chemical issue where they're not actually able to get oxygen out of that air into their body. So, if somebody's choking, there's something stuck in their throat, that is a mechanical issue. They're not able to get air down into their lungs, but if they could, it would be working fine. Versus somebody who has like pneumonia, where there's a bunch of like mucus and stuff blocking those alveoli, and it doesn't let air through, and it doesn't allow that gas exchange to happen, which would be a respiratory or a chemical issue, right? So when we think about human breathing, think about it in two different ways. A mechanical, a pump, a balloon expanding, air physically going in and air physically going out, versus like a chemical problem where the actual gas exchange is happening and getting that oxygen into our blood. So for us, that means if somebody is having a ventilation issue, if they are not breathing, if their diaphragm isn't working, we can breathe for them. And you as VEFRs, we're going to be able to use this pocket mask, right? And I'm going to teach you how to do that at GIV. Whereas at the EMT level, we have something called a BVM, where we can essentially provide oxygen via pressure like this. We squeeze the bag and it inflates their lungs. And then if somebody is having a respiration issue, you as VEFRs can assist them with their inhaler if they have one, right? You can hear that wheezing. You recognize that they're having trouble breathing. You know that it's not a, ventilation problem. They need a chemical to help them get that oxygen into their blood. So help them with their inhaler. Or me at the EMT level, we can give them just straight up oxygen to try to increase the amount of oxygen going into their blood. So again, breathing is two different things that we need to think about. That ventilation, mechanical, and respiration equals chemical. Any questions about that? Okay, cool. Thanks for letting me take a drink of water. Now, how we can start helping people in these situations if we recognize that they are not breathing or something is going wrong is by what we call airway maneuvers. So one of the more common reasons why somebody might be like having some difficulty breathing, especially if they are, unconscious, right? Somebody laying on their back, not conscious in a, it's not that they're sleeping, it's that they have a traumatic or a medical reason why they're not awake. This leads to like a loss of muscle tone in the throat. And so if you're laying back and you're in a weird position, right? If you try to take a deep breath, you're going to hear that snoring. And that's because the tongue is actually blocking part of the airway. So we will do something called what we call the head tilt chin lift, where we essentially put a nice gentle hand on their forehead and under their chin, and we tilt their head back. Because what this does is it creates a more straight line for that airway, right? You can see here that this is kind of like a 90-degree angle, right? Air comes in here, it's at the back of the throat, and then it has to work to go down that straight angle. Whereas if we tilt the head back, it's a little bit more of a straight line. It's a little bit of a curve, right? But it reduces the amount of work and obstacles that air has to go through. So this can really help. If somebody's doing that snoring, and then we do this, it's going to help them breathe because it's going to reduce the amount of blockage or obstacles that it has to go down. Now, the important thing about this is we're only going to use this on people who we suspect not to have had a traumatic injury. We're worried about their C-spine, right? What is this position? What does the head tilt chin lift do to that C-spine that we consider to be so important? What does it do? Yeah, exactly. It bends it, right? So if you're sitting here and somebody has a C-spine issue, they have a broken neck, and we do the head tilt chin lift, we are directly messing with that really important part of the spine. It could make it compress, it could make it get more damaged. So we can only use the head tilt chin lift on somebody who isn't suffering from like a head, neck, or back injury. So if we show up and somebody was struck by a car or something like that, we're not going to use the head tilt chin lift because for worry of damaging their C-spine. But don't worry, we do have another maneuver that we can use called the modified jaw thrust. So the idea of this is that it's the same. We're trying to reduce or increase the amount of space at the back of the airway at the back of the throat to allow more oxygen in, whereas we're not going to be messing with that C-spine. So like what we do here, I don't know, it's kind of hard to see when I'm dark. We're going to essentially push the jaw forward. We're trying to give them an underbite, like a bulldog, right? We're trying to lift that jaw away from the back of their throat to relieve some of that pressure without moving their C-spine. So we push forward, give them that underbite, and it will open that back of the airway without us moving their spine. So this is only used for trauma patients, right? And then what's something else that we have to consider about the jaw thrust? The head tilt chin lift, pretty much we can hold very easily, but the jaw thrust, not so much. So what does that mean? Once we do a jaw thrust, is it just one and done? No, we have to hold it, right? As soon as we let go, exactly. As soon as we let go, the jaw just goes back to its normal position, potentially blocking the airway. So you have to sit there, and if you're doing a jaw thrust, you're going to be holding it for a while, right? You might have to hold it until an EMT shows up and can put in a specific airway. So this is one of those things. It could really help save someone's life, but it's one of those, like, we're going to be there for a while. If we are just by ourselves and we recognize someone had a traumatic injury, they're not breathing very well, we can use the jaw thrust to open their airway. and that might help them breathe, but we have to stay there and we have to keep that jaw open. Okay, so we're moving on to the circulatory system. Does anyone have any questions so far? We're blowing through, even if you can't see me. That's too far away, right? Okay. So, the circulatory system. This is that C of our ABCs. It's what circulates the blood and the oxygen out to our internal organs. It is really important because every single cell, every single minuscule microscopic part of our body needs oxygen. And this is how it gets there, through our blood. It removes waste products too. So whenever you take a deep breath in, you get fresh oxygen out to your internal organs, and then they use that oxygen, they burn it, it turns into carbon dioxide, CO2, and then you breathe it out, right? And it's comprised of quite a few different little structures. We actually have like miles upon miles upon miles of blood vessels inside of our body. If you lined them up end to end, just from one of you, it could wrap around the world at least once, right? We have so many tiny little blood vessels and tubes packed inside of our body. It's kind of insane. And it's all connected. It's all one closed system. And so it consists of a few different things. And this is why one of those, like the example of that heart or the human body really helps me learn this. Because if you think about like a system with water, right? A pump. Your heart is the pump. Your blood is the water, and the tubes, the pipes, are your arteries and your veins. So when the heart beats, it sends blood circulating through those arteries and those veins, and then it brings it back into the heart, and it just keeps circulating through the lungs to get new oxygen and then release the stuff that has been used. Now the heart itself is really cool. It is 4-chambered organ, so it's a muscle that has 4 different chambers where blood comes in and where it gets pushed out. It also has its own blood supply, right? So this is a heart right here without all the muscle tissue. So if we're talking about a heart attack, this is what we're talking about. If one of these vessels is blocked, right, by a clot or something, all of the tissue of that heart muscle underneath where that blockage is going to start suffocating because it's not getting the oxygen that it needs to function. And that's what is a heart attack, is that when the heart tissue is not getting the oxygen that it needs due to a blockage. And then it also like brings oxygen, deoxygenated blood in, so all the stuff that's been used, and then it circulates it to the lungs, and then it gets oxygenated in the lungs, then comes back to the heart to be spread out through the body. And this is the actual like written down pathway of the heart. Now, you don't have to memorize this, but if you do want to impress me, I do think it's really important. Once you get to that EMT level, it's one of those things that can really help you. There are quite a few conditions where if you know the actual pathway of blood through the heart, you can pinpoint and say, oh, this person's heart is failing on the right side because I see blood backing up into their legs. Or I hear liquid in their lungs, so their heart is failing on their left side. Because deoxygenated blood, right? Blood that's used up its oxygen, comes into the heart through what we call our superior and inferior vena cava. So just really big vessels. The inferior is the one that comes up from the bottom. It essentially brings the blood from your lower extremities up to your heart. And then the superior is the one that brings it down from your upper torso and your brain. They enter the right atrium, which is this small little section right here. It then goes into through the tricuspid valve, into the right ventricle, through the pulmonary valve, which means the lung valve, right, into the lungs. And they go through what we call the pulmonary artery into the lungs, where then that blood is oxygenated. And I have this color coded because blood that is not oxygenated will be a much darker, closer to purple color, but not really this, it's not truly blue or purple. It's just gonna be very dark. And then when it gets oxygenated, it becomes a bright red color. So in the lungs, that's where the oxygenation occurs. It will then come back to the left side of the heart, into the left atrium, through the pulmonary veins. It goes through the bicuspid valve. It's also known as the mitral valve, but it helps me to remember that tricuspid becomes before bicuspid, because you should try something before you buy something. And it goes to the bicuspid valve into the left ventricle, which is like a really big powerhouse ventricle, and then it pushes it out through our body. So when it's in action, right, you see this happening. Blood comes in into the right atrium, down into the right ventricle, out into the lungs where it gets oxygenated, back into the left atrium, down into the left ventricle, and then it pushes it out through the body, and that's where you feel your pulse. So if you can feel your pulse, you are feeling the work that your left ventricle is doing. But really, your heart has two beats. It's one beat that we can't feel. It's the atrium beating. And so if you ever listen to your heart, you're going to hear something more along the lines of lub-dub, not just a beat. Whereas if you feel a pulse, you're just going to feel like one beat, right? And you are feeling the pressure that your left ventricle is exerting onto the lungs. Or not onto the lungs, sorry, onto those vessels. So it goes out to the body. Now, in order for the heart to do this, it needs to have some of its own electrical system. And it does. Now, this is how it beats. This is how it is able to function and then, circulate blood through our body. It has what we call nodes and Purkinje fibers. So really, just think of this as like wires, right? We have these little tiny computers that essentially tell it when to release a electrical signal, and then it goes through the wires and it inspires the tissue of the heart to beat. So the SA node, or the sinoatrial node, is what we consider to be our pacemaker. This is what we use most of the time. This is what we use as healthy adults. This is just going to keep us at a normal heartbeat. Does anyone know what the normal range for a human heart is? What the normal beats per minute are? Yeah, 80 to 100, technically. Anything above 120 is what we consider like fast. But yeah, you're absolutely right. So that's what the sinoatrial node is doing. It is keeping us at that range between 80 and 100, or like 60 and 100. Whenever we do have an issue, though, if that SA node isn't functioning, we do have a backup node. It's called the atrioventricular node, the AV node. This essentially, it's not enough to like really keep somebody alive all that well, but it does keep the blood circulating. This one is much slower. It's probably like, I think it's like 40 to 60 range. So it only essentially kicks in if something goes wrong with the SA node, and it just hopefully keeps the heart circulating some blood a little bit. But it's really a backup plan for if something goes wrong with that SA node. And then those Purkinje fibers are those little tiny wires that go through, and that's that receives the signal. And so when the SA node beats, the atrial goes, then the ventricle, and then the atria, and then the ventricle. Now we've got the fluid in our pipes, the blood. So your blood is made up of quite a few different things. In fact, it is made up of plasma, which is kind of like the liquid of it. One of my first jobs outside of college, I worked in a plasma donation center as an EMT. It was kind of fun, and it's really kind of cool. You get to see the blood get separated into plasma. And so the red blood cells, that's what actually gives it its red color. Whereas the plasma is more like this kind of fluid, or like straw kind of color like that. It's more like a yellowish kind of color. It's really salty. It contains a lot of proteins and things like that. But people can use plasma to create life-saving medications for people with like autoimmune diseases and things like that. Whereas the red blood cells carry the nutrients like oxygen and all that stuff out to our cells. From here on out, start picturing like red blood cells as little tiny buses, right? They have lots of little seats on them, and they make stops on their way throughout the entire body. They let things off. They let oxygen off into the cells. They pick up CO2. They bring it back to the lungs to get them out. It's really just like a little tiny bus system. And when we start talking about things like SpO2 monitors, that's what we're going to be measuring. It's measuring how many seats are bound on those red blood cells, those hemoglobin. Now, other things in our blood are things like white blood cells, which is part of our immune system. They fight off infections. They're carried around the body through the blood. They don't necessarily have like a main process in the blood, but they are in that transportation system getting out to where they are needed. And then platelets, these are little tiny cells that essentially help us stop bleeding. So if you've ever gotten a paper cut before, right, it's going to stop bleeding on its own. You know, direct pressure helps. Like that's one of the things we're going to learn when we talk about stop the bleed. Direct pressure is going to help your body clot, but unless you have a condition like hemophilia or something like that, your body can stop its own bleeding up to a point. And then platelets are how it does this. So if you've ever gotten a cut and then you have a scab afterwards, that's what those platelets are doing. They essentially stick together, they plaster themselves over the gap in that, or from where that cut is, and then they start to stop that bleeding. They create a scab, and then your body starts to heal. So like that's the purpose behind them. Let's see if I've got some juice in my light. Ooh. All right, it's working. We'll see how long it lasts. But all of these together make our fluid, make our blood, and we really need to continue to have this in our body. If we don't have blood in our body, it essentially is just going to be a bad time, right? We need that oxygen. We need the platelets. The main big thing is the red blood cells that carry the oxygen and remove the waste and things like that. But this is why if somebody is bleeding, if they bleed too much, that's why we die, because they essentially don't have enough of these cells, enough of that fluid to get oxygen circulating to the rest of their body. All right, before we continue, it is 12:30, so I think it is a good time to take a break. We're about halfway through, so come back at, let's say, 12:45. How's that sound? 15-minute break. Coolio? All right, see you in a little bit. All right. So, our circulatory system, we were talking about the heart previously, and the blood through those pipes and that pump that we have for the heart. So this is a breakdown more of the different types of vessels that we have. We have arteries, veins, and capillaries. Now these are just kind of like the generalized lists of what we have. We really have more than this. Arteries break down into arterioles, which are smaller, right? Veins are even smaller when they go venules, and then we have those capillaries. So this is how our blood system works. Oxygenated blood from our heart gets sent out through arteries. Arteries are big, they're high pressure vessels that are able to withstand like the beating of the heart, and that's where we feel our pulses. So if you feel your wrist or if you feel at your neck, you are feeling an artery because that's what is connected directly to the heart after it beats. It is sending the blood out. We are feeling the pressure of that heartbeat in our arteries. So that's what carries the blood out to the body tissues. And the big thing here to remember, especially on Thursday when we start talking about like trauma and stop the bleed and things, arterial bleeds are a lot more severe than like a venous bleed or a capillary bleed because it is high pressure and it contains that oxygenated blood. Whereas veins, these are a little less protected. Arteries are really deep down inside our body. The places where we feel those pulses are where they come closest to the surface. But they're really kind of buried in because they need to be protected. Whereas veins, oftentimes, you can see, like on the back of your hands or on your on the inside of your elbow, right, where people do IVs and things. You might even see them all across people's arms, depending on their anatomy. But these veins are what returns the oxygen-depleted blood back to the heart. So they're typically smaller. They're not as high pressure because they're not actively receiving the pump of that heart. And the blood is deoxygenated. So it's coming back to those through those inferior and superior vena cava into the heart to then be reoxygenated in the lungs. Veins are what we use in medicine to like put medicine or extra fluid into somebody's body. So as an advanced EMT, I can do what we call an IV, an intravenous injection. So I can take a needle, I can put it into a vein, and then I can put either just like fluid, like saline solution if somebody's dehydrated or they've lost some blood, or I can put in certain medications. Because if we put a medication into a vein, it's going to go directly to the heart, where it's then going to be circulated out through the entire body. So it's a really quick way of getting that medication into somebody's body. Now, capillaries is where these two structures connect. So arteries go into arterioles, they get smaller and smaller, and then capillaries is where that oxygen exchange between cells and the CO2 happens. So if you look like at the back of your finger, right, your nail bed, if you look at it, it's probably like a normal skin color condition for whatever your skin is. Now, if you press on it, it's going to go to a lighter color because you are pushing out all the blood in your capillaries. And when you release, it should go back to that normal tinge that it is, right? And so the capillaries that we have are actually really, really small. They're like microscopic. And at any point, if you're just like squeezing on a part of your body and it gets that lighter shade and you let go, you're going to see the capillaries refill. If you've ever gotten like a paper cut or even just like a small cut on your arm or something, you are seeing capillary blood because if it's really shallow, if it's not going deep into those veins or to an artery, it's really just going to be like oozing a little bit of blood. It's that the area at which, the oxygenated blood is getting rid of the oxygen and taking its waste products back to the heart. So capillary bleeding, not super dangerous, right? Very few people, almost probably none, would be killed from capillary bleeding. It's almost impossible to like truly bleed out from capillary blood. Whereas if veins or arteries are damaged, depending on the severity of that wound, they could be. That person could be in a lot of danger. especially when we're talking about arteries, right? Unfortunately, movies and stuff, TV shows, Grey's Anatomy, they don't do a good job of necessarily being totally accurate for medicine. But one thing that movies do pretty well is arterial bleeds, because it's pretty dramatic, right? If somebody gets hit in an artery, you see that like spray of blood. That's relatively accurate, because arteries are that high pressure. If they are damaged, they start to spray the blood out because they're in time with that heartbeat. So somebody who has an arterial bleed is likely to die a lot faster than if somebody has a venous bleed, because veins aren't that high pressure. It's going to be more like oozing or pouring or kind of just like draining out versus spraying. And then capillaries, they just kind of like ooze, right? If you got in a paper cup before, you look down, you're like, oh, and then you can kind of start to see it well out. That would be because they're low pressure, they're small, and it's just a little bit of blood coming out. Now, places like our face and our head, we don't have a lot of skin and a lot of fat and tissue up here, right? If you feel your forehead, you can pretty much feel your skull underneath with not a whole bunch of padding. And so if people get hit in the head, like face injuries, like little cuts on the forehead, they tend to bleed a lot because there's just a lot of capillaries in those areas, but not a whole lot of big arteries or veins, just like on the front of our faces. So this is where that oxygen exchange actually happens, inside the cells, inside our skin, all that kind of stuff. And me showing you that trick of like pinching your finger and looking at the color change, that is actually something we use on the ambulance. It's a really quick way to like look and see if somebody has good circulation through their body. If somebody, you squeeze it and you look down and it's not immediately coming back to its normal skin pigment, that means that the blood essentially is having a harder time getting down to those extremities. Now, it could be due to like a low blood pressure, or it could be due to something like shock, which we're going to talk about in a little bit. But it's a really quick way to, without checking somebody's blood pressure, to look at it and say, oh, they're having a circulation issue because I see that their capillary refill is more than 2 seconds, right? It should be less than 2 seconds for a healthy person. Now, this is where, when we start talking about these vessels, this is where we start to get into the idea of what we call vital signs, right? What we're going to be learning how to assess at GIV is where to check for somebody's pulse, how to feel somebody's pulse, and then we're also going to be like counting how many times a minute that heart beats, because if it's too slow, that's an issue, or if it's too fast, that's another big issue. So we need to be able to just like find where we can assess that pulse, count it for 30 seconds, multiply that number by 2, and we've got how many times that heart beats in a minute. Now, the pulse is also tied to the blood pressure. Now, what we are actually measuring with a blood pressure is how hard the heart is working to circulate blood, right? How much resistance or force against the walls of arteries and veins. So whenever you go to the doctor, or you get that thing put on your arm, the cuff, and they pump it up and it gets really tight, and they listen with a stethoscope to the inside of your elbow, they're listening for your pulse. So how you essentially check a blood pressure is you pump up that cuff until it's really tight. And so you turn off the circulation in that arm essentially, and then you start to relieve the pressure by opening up the valve, and you listen for that pulse to come back. And the numbers on that, the dial that bounce up and down when you look at it, that's what gives you the actual blood pressure number. And we have 2 numbers for it. So if you've ever heard your blood pressure talked about, it's like 120/80. And the higher number on top, always lower number on the bottom. And we call those numbers the systolic blood pressure and the diastolic blood pressure, or systole and diastole. So what we're actually physically measuring is, when we're talking about the systole, we're talking about how hard that left ventricle is contracting. So that left ventricle, right, remember, it's the one that when you pushes the blood out to the body. So we're really measuring how hard the heart is working to circulate blood. So it should always be a higher number than the diastole. Now, diastole is measuring how hard the heart is working to relax, to refill with blood, right? When it pumps out blood, how hard it was working to do that, and then when it refills, how hard is it working to do that as well. Now, this is why we start worrying about circulation, because the blood pressure is directly tied to what we call the perfusion. How well is somebody circulating their blood out to their internal organs? In general, I've been saying the systole needs to be higher than the diastole, because the number should always be higher when your heart is working hard. It should not be high when it's trying to relax, right? This is why people with high blood pressure end up having heart conditions or developing strokes and things like that, because if your heart is working really hard to relax, that's not good. It should be working hard to pump blood out, but it should not be working hard to bring blood in. So if somebody has like a consistently high low number and a consistently high high number, that's where their heart starts to essentially get bigger, and it shouldn't do that. It starts to get too big to actually function. And if somebody has like a really high systole number throughout their life, they're putting a lot of damage and pressure onto those microscopic vessels in their brain, right? If you think about the pulse as a little tiny group of guys running through your veins with little tiny hammers, and they're checking the quality and the structure and how strong those vessels are. They're hitting on the walls of your blood vessels with little tiny hammers. The higher your blood pressure is, the higher and harder they are slamming on those walls of the vessels. And so sometimes how strokes can get started is because somebody has a really high systolic blood pressure for a long time, and it's really just like a bunch of big hammers slamming against those blood vessels until they eventually break and rupture in what we call like an aneurysm, right? Whereas if somebody has a high consistent diastole, their heart is working really hard to relax, and so those muscles are getting bigger, they're getting stronger, but not in the good way. They're just becoming large, and eventually the heart becomes too large, it can't beat appropriately. So that's why we measure blood pressure, because we want to know, is it affecting their brain? Is it affecting their heart? Or, is something going on where maybe they have lost some blood and their blood pressure is now lower because they don't have as much blood in there? So the pulse and the blood pressure combined brings us to the idea of what we call perfusion. It's the idea that blood is actually circulating out to all the really important parts of our body. And if the perfusion is not high enough, if it's a low perfusion, then we know that somebody is in a bad way. Because if it's inadequate, if the perfusion is not doing well enough, the body really starts to struggle, and it goes into something called shock, right? We're going to talk about that in a little bit. But perfusion is one of the more important things. And this is a circulation issue, right? If we're going back to those ABCs from the beginning of our session today, if somebody has not enough perfusion, their circulation is not effective, their body, their internal organs, it's not getting all the oxygen and stuff that it needs, they're starting to struggle and suffer, and that can lead to somebody's death. So circulation is also directly controlled by the brainstem. Again, we don't think about it. Our heart just beats on its own. It manages it even when we're asleep. It just takes care of it for us. Oh, sorry, Jaron, I didn't see your question. So one of the tricky things about a VEFR certification is you are not allowed to directly take the first set of vital signs, including a pulse oximeter. A licensed EMT needs to take the first set of vital signs on a patient. However, after that, yes, you can. And we're going to be showing you how to use pulse oximeters. We're going to be talking about them. But again, the VEFR certification is one of those ones that's a little bit interesting with like the scope of practice, which is a word that we'll be talking about a little bit later. So yes, you can like look at the reading of it. You could put it onto somebody's finger, but you can't be the first person to do it, if that makes sense. You need to have an EMT or higher put it on, and then they could be like, hey, Jaron, what does the pulse ox say? And you could tell them what that number is. And we'll be explaining like what the good numbers and bad numbers are and stuff like that. Yes, Zoe, we are going to learn how to use a stethoscope. You do need to use one in order to like take a blood pressure. And I think we have like respiratory therapists coming to GIV. If you've signed up for something like that, you'll definitely be, using a stethoscope. And then when we do vital signs, you need a stethoscope in order to assess a blood pressure as well. So for sure. So again, circulation, it's adjusted and controlled by the brain stem, right? That part in the cervical spine that we've been talking about. What it normally does is if we like lose blood, right? If you start to bleed and you bleed a lot, that system will automatically try to, keep your vital signs relatively normal. So as soon as we start losing a lot of blood, the brain stem is going to start telling your body to make its arteries and veins smaller, because if there is less fluid in that pump system, if the water level is here, too low, if we make that smaller, it's going to like keep the blood pressure relatively normal. It's going to make it so that the heart can continue to circulate whatever blood is left. This is also going to increase the pulse, because if we don't have enough blood, we need more oxygen circulating to our internal organs. So we quicken the pulse and our blood pressure goes up initially. So it's kind of interesting, because you might see somebody who has lost a lot of blood and after an accident, and you check their vital signs, and the only thing you might notice to start is that their pulse is a little bit fast, but their blood pressure might be totally normal. When you'd expect it, like, wow, that's a lot of blood, I'm expecting to have a low blood pressure. But that's because our body is actually really good at getting hurt. It has a lot of backup systems and has a lot of things to keep us relatively normal when we're injured and when we're sick, so that we can get to help. So initially, somebody's blood pressure is going to stay the same, even if they're actively losing blood. It's going to try to keep itself normal. Their pulse is going to increase. The respiration rate is going to increase, because it needs more oxygen to put into that blood to then circulate out. However, it can only do that for so long, right? It can only do what we call compensation for so long. After that, it's going to rapidly decline, where somebody's pulse is going to start to drop, their blood pressure is going to start to drop, and their respiratory rate is going to start to drop. That's a bad sign. This is known as shock. But first, we need to clear something up.
Dr. Kim there? What is it?
You know, I grew up on a farm. I grew up on a farm, so blood doesn't bother me. I slaughtered a pig once. That was a lot of blood. Bleeding like a stuck pig, that's a saying. To bleed like a pig, it means something, but you don't think of people as having that much blood. I mean, you learn in med school how many pints we all have in us, but you don't realize it until you see it. You don't get how much blood in skinny person. I mean, my God, Reed, she's like almost anorexic. She's like 5 pounds. You wouldn't think she'd have that much blood in her, but she did. She did.
You're in shock.
No! Oh! And this guy's supposed to be a medical doctor. What the heck? He just said she's in shock. This guy's McDreamy? Come on, man. This is why I don't like Grey's Anatomy, because sure, they're hot and it's drama, whatever, but it's not medically accurate, okay? When somebody is scared or upset, it's not shock, okay? All right, I'm calm. I'm good. Here's the deal, okay? Being shocked, triggered, or traumatized by an intense event is not the same thing as shock, okay? You can have a strong psychological response that inhibits your ability to function, like we saw April going through, okay? But that's my biggest pet peeve, is when like doctors and stuff like, oh, you just got upset, you're in shock. No. And I'm sorry that I made fun of it, but it's a bad medical show. It's great. It's very entertaining. But if you want to watch it and be like, oh, this is very medically accurate, I'm sorry, you're wrong. I've just heard too many people be like, oh, I want to be a nurse. And I'm like, oh, cool, why? And they're like, Grey's Anatomy. And I just immediately am like, oh, you're one of them. Okay. So I just wanted to clear this up. Shock, also known as hypoperfusion, right? Too low perfusion is a serious life threat. April in that situation was not going to die. Her heart was working just fine. She was circulating blood great. All right? The woman that she was treating, not so much. Okay, so saying, April, you're in shock, this is a plot device and has no medical value. Shock is when somebody's internal organs are not getting the appropriate amount of oxygen. All right, so you can look like this. You can look like this. But until you look like this, being bagged by EMT Jeff Shelton, you are not in shock. Okay? All good? Don't make me show you more Grey's Anatomy. I will, I promise. And if you... Okay, we're done. I'm off my high horse here. So let's talk about how we can treat it, right? It's actually relatively easy what we can do. Now, again, as VEFRs in this first response and first aid, we're not going to be able to get down to the necessarily like internal reason why somebody is going into shock. There are a lot of reasons it can happen. It can happen due to infections, like body-wide infections. It can happen due to allergic reactions. It can happen due to heart attacks. It can happen due to blood loss. It can happen due to a bunch of different things. So what we need to do is be able to recognize and have a suspicion of whether or not somebody is actually hypoperfusing, not circulating blood well enough. And what we can do to help it is we're going to essentially, try to stop any external bleeding. So after Thursday, when we do stop the bleed, you'll understand like what would be necessary. We want to immediately stop them from losing any more blood so that their body doesn't have to keep doing this. And then after that, our goal is essentially to help their body compensate. Again, like I was saying before, your body is really good at getting hurt. We have a lot of backup systems. When we start to go into shock, your body is going to keep itself normal, keep that blood pressure normal as best it can by increasing the pulse, the respiration rate, and the blood pressure. That takes a lot of work for the body to do, and it can only do that for so long, right? It can only do that so many times. So what we want to try to do is support the body and make it so it doesn't have to work as hard doing other things. So if you recognize that somebody's in shock, you really want to make sure that other people are on the way to help. Like EMTs, an ambulance if you're by yourself or something along those lines, call for help. Yes, someone can still be awake and in shock. The difference is when they are compensating versus when they are decompensating. Somebody who is in compensation, it's going to be that they are essentially, they know about their injuries. Yeah, they were not going to be oblivious to their injuries. Oftentimes, they know that they're hurt, right? If somebody's been bleeding a lot, they're really going to pretty much feel normal while they're compensating, right? Because their body is working extra hard to keep itself normal. But when it starts to lose that ability to do so, we call that decompensation. And somebody's going to start to get sleepy. They're going to get really tired. But while somebody is compensating, they're going to feel very anxious. They're probably going to be really alarmed because they don't feel great, but they don't feel like they've got a big injury. They know that they're sick, but their body is keeping themselves normal. Whereas when they start to lose that ability, they're going to start to get sleepy. That's why, we want to urge people to stay awake, because if they pass out, that's a bad sign. Their body's going to start to shut down even more. So the things that we can do to essentially help them compensate is preserve their body heat. One of the most energy expensive things that we do is generate body heat. Even if you're just sitting there, right? I mean, you might not have to in Vermont right now where it's nice and warm. You're probably not generating that much heat. The outside world is doing it. But even if it's cold, right? One of the more intensive things that our body does that burns a lot of energy is creating body heat, burning the oxygen to create that heat. And if somebody is compensating, we don't want them wasting their body's energy on creating heat, because it burns so much that they're going to decompensate a lot faster if they don't have some warmth. So one of the first things we're going to do is preserve their body heat. We're going to wrap them in blankets. We're going to turn up the heat in the area or the back of the ambulance if possible. And so we are essentially insulating them, making it so their body does not have to work so hard to generate heat. If we can remove that body's work to keep them warm, we keep it warm for them, their body can use more of that energy to keep itself compensating. The other thing we can do is use gravity to our advantage. So we're going to lay them flat on their back in that supine position. Because even me, standing up here right now, just standing in general, my body is fighting against gravity to circulate blood up to my brain, and then also to recirculate blood up from my legs back to my heart for recirculation. My blood pressure is inherently higher when I am standing because my body has to work against gravity to move it back up. So if I lay somebody flat, right, it's much easier for the blood to circulate because it's not fighting against gravity, it's just staying at this one level. So I'm removing that body's effort to essentially lift and pull that blood back up, reducing the effort that the body needs to compensate. And then the final step is going to be providing them oxygen. So that's why we need to call for the additional resources if you are by yourself, because at least an EMT needs to be there to essentially apply oxygen to them. Because we want to pump them full of oxygen because their body doesn't have enough. Oxygen is the thing that it needs. If they don't have as much blood or their perfusion is low, we essentially want to make sure that they have as much oxygen as possible. So you can see in this picture that this EMT is bundling up this patient. They have bandaged a wound. They put blankets underneath them. They've laid them flat. They're putting blankets on top, and they're giving them what we call high flow oxygen. So they're just really making sure that this person's body can continue to compensate. We are not fixing the internal issue, right? If they had a really bad arterial bleed, they're going to need surgery. If they had like a heart attack or something along those lines, they're going to need surgery. We can't do that in the field. But what we can do is essentially support their body for long enough to get them to a place where they can have that surgery done, where they can fix the internal issue with the airway, the breathing, or the circulation. So the other thing about shock is that just like we were saying before, that person might not necessarily recognize that something is truly wrong. They might know they've been injured, but their body is tricking them. It is keeping them normal. And so it's really along the lines of, we want to treat them for shock before we start to see physical signs of it. If we wait to lay them flat, give them oxygen, and bundle them up until we see their pulse and their respirate and their blood pressure start to drop, it is too late. Because people present relatively normal, maybe higher pulse and higher respirate, but normal blood pressure, it can trick providers. And a lot of people are like, oh, you know what? You don't actually seem that injured after that accident. Let's just get you in the back of the ambulance and start going. And then 5 minutes into transport, that person is sleepy and passing out and their blood pressure is dropping. We want to treat them for shock before we start to see the bad signs and symptoms. So really, anytime that we see like an injury or an illness, that when we look at it and we're like, ooh, I'm suspicious, right? How are you still okay? That is not a sign of I'm missing something. It's a sign of, oh, they're in shock. I need to start helping them compensate before they start to decompensate. Does that make sense? We want to be suspicious so that we can help them compensate before it gets worse. Okay. So the last part of our section today is we're going to be talking about some emergencies and how to recognize them. And then we're even going to talk about the first medication that you're going to be able to give. First things first, let's talk about how to recognize inadequate breathing. All right. So whenever we're looking at somebody and we're assessing how they breathe, we're going to be looking for a few things. We're not just looking for how fast or how slow they are, but we're also looking for the quality of their breaths, right? If somebody just sprinted, if you're an athlete, right, and you just ran a mile or something, you're going to be breathing faster because your body has been burning oxygen, it needs it. However, if somebody's just something like sitting there and they're breathing really hard and it's like, that's bad quality. Right? So it's not just about the speed, it's also about the quality of the breath. Do you hear any abnormal sounds? Do you hear wheezing? Do you hear gurgling? Do you hear snoring? Right? Also, is it like really fast? Like, or really slow where they're breathing like a couple times a minute? That's always really bad. So other things that you might be able to see is what we call pale or cyanotic skin. cyanosis is a blue tinge to somebody's like central circulation. So we oftentimes see it on lips and tongues. People who have darker skin, it's a little bit easier to see like on gums or the fingernail beds too. I think I have a picture in here too. Yeah. So people with darker skin, it's a little bit easier to see on the tongue than it is on the lips. So just keep that in mind depending on who your patient is. But essentially this says that they do not have enough oxygen. If we're seeing cyanosis, this means that their body isn't able to get in oxygen and circulate it as well. So that's why if you see somebody not breathing very well laying on the ground, they might appear blue or like purple because their body is not getting enough oxygen. The other thing that can be pretty easy to assess is the quality of their skin condition. So if you like touch their arm and it feels really cold to the touch or cool, or they're like sweaty but their skin is chilly, that's what we call clammy, right? That means that somebody is working extra hard to breathe and their body is suffering from it. The other thing you might see is something called the tripod position, where somebody is leaning forward, usually with their hands on their knees, trying to breathe a little bit better, right? You do this too. If you just ran and you're out of breath, you just, because what you're doing is when you lean forward, you're using gravity to help expand your chest, where your diaphragm's been working a lot and your ribs have been working a lot too. When you lean forward, it's a lot easier to take a breath because gravity is helping expand your chest. So people with difficulty breathing are oftentimes sitting in their chair, clutching their legs, trying to breathe, or like standing up and leaning forward, trying to get that gravity to help them. So if you see somebody leaning forward, touching their knees, having difficulty breathing, maybe some cyanosis around their lips, immediately you can say, ooh, that person is not having an easy time breathing. And then when it gets really bad, we can start to see accessory muscle use. This is muscles that are in between your ribs. You don't even really think about them that you have them because we don't really use them that much. But somebody who is breathing or having a really hard time breathing, if you look at their rib cage or up here at their clavicles, you might see like little muscles contracting, trying to keep, like move their ribs in. And that's a sign that they're going into what we call respiratory failure because their body is working too hard. They're losing their ability to breathe, and eventually they're going to get too tired, and they're eventually going to stop breathing. So accessory muscle use is a bad sign. If you look at somebody's exposed rib cage or like up at their clavicles, you're going to notice like the muscles going in, there's going to be like indentations in their breathing because their ribs are trying to contract to help exhale a little bit more. And then the other thing on this list, those agonal gasps, this we need to talk about. It's going to come up more when we do like CPR and cardiac arrest and stuff. But agonal gasps, this is where somebody's heart has stopped or it's about to stop. However, they look like they're still breathing. So I'm going to show you a video. This guy is not going into cardiac arrest. He's just an incredible actor. I have seen plenty of agonal gasps, and this guy does it really well. So my point with this is that you need to recognize when somebody is actually breathing versus when it's essentially like a nervous system response, the last ditch effort trying to get some your oxygen in. So somebody who goes into cardiac arrest pretty much immediately, right after that, they're going to start to have agonal gasps. And this is actually a pretty big barrier for people who do not know about them because oftentimes they show up, they call 911, they're like, well, I don't know if they have a heartbeat, but their mouth looks like they're breathing. So breathing for us is all about chest rise and fall and not mouth gasping. So let's look at this video. So, I mean, a little uncomfortable to watch, right? Like, if you see somebody doing that, it's not good. And the point here is, again, that even though their mouth might be moving and you might be hearing like those snoring and those kind of like gurgling sounds, the cheeks flapping, it's not actually getting air down into their lungs. So that's a big thing. If I see this, I'm going to say that this person is not breathing. They're having agonal gasps. And the next thing I'm going to do is I'm going to check for their pulse, and I'm likely going to be starting CPR. Because good, adequate breathing for us involves chest rise and fall, right? If you take a deep breath, your chest moves up, and when you breathe out, the chest goes down. So that's what we're looking for, is the lungs expanding, not just the mouth gasping or making those noises. So a lot of people can get confused when they see somebody in cardiac arrest and say, no, they're breathing. But this is the body's, like the spinal cord is doing its last ditch effort trying to get oxygen into the body, and it's not working. So just keep in mind, this agonal gasping is not breathing. It basically tells us that that person is either in cardiac arrest or very close to it. Okay, so a little bit different than like difficulty breathing. This is what we'd call inadequate breathing. It's not breathing really at all. Okay, so that's our respiratory side of things. Now we're going on to the cardiac. So heart disease is actually a large reason why a lot of American people die every year. It kills approximately 700,000 every single year due to things called atherosclerosis, which is essentially buildup of plaque inside of our arteries, inside of our heart. Hypertension, that high blood pressure, can lead to like heart attacks and strokes and other issues. Angina is essentially a warning sign for a heart attack. And then a myocardial infarction is when somebody truly has a heart attack. So all these things contribute to why chest pain is a big deal. You know, it's just kind of a thing about our country. We do not have a lot of easily accessible like healthy food. Healthy food typically seems to be a little bit more expensive. The cheaper stuff like McDonald's is full of sodium and it just raises our blood pressure. It's just like the fact of being an American. We typically have higher salt contents in our easily accessible food, which contributes to like cardiac stuff like this. And again, I put up this picture of the heart and its blood vessels so that I can remind you that like if we're having a heart attack, it's one of these blood vessels that's being blocked. Either a clot has broken free somewhere.
Girl too, Susie girl.
So that jump scared me, Zoe. Sorry. So one of these vessels, if it's blocked, like a clot gets busted from somewhere else in the body and travels and gets stuck here. Or if we're talking about atherosclerosis, where plaque builds up in these arteries and eventually clogs them, any blood that gets stopped at that blockage, that section of that heart tissue is going to die, and that's what we consider like a heart attack, right? So that's kind of the point behind this. So going on more with that atherosclerosis, I have this kind of image for you here. This is like a normal vein or an artery, right? We've got the exterior wall and the blood on the inside. It should be clear and open for the blood to flow through into the heart, bringing the oxygen to where it needs to go. However, if there's a blockage, right, that amount of blood that's able to get by is drastically reduced. It might not be a full blockage, but it could be some, right? And anytime that the amount of oxygen that heart is receiving is decreased, that's going to present as pain. So when someone starts having chest pain, it's because their heart is not getting enough oxygen, right? It's hard for that heart muscle to breathe. So at an EMT level, we have a medication called nitroglycerin, which we can essentially give somebody to help reduce this amount of pain. And what we do is it's a little pill we put underneath their tongue, and the goal of it is that it widens veins and arteries. It makes them bigger. So if we can widen that artery around the clot, right? We give them some nitroglycerin. The clot stays the same size, but the artery gets bigger. We just allow more blood to get to the heart around that blockage. So it's not fixing the blockage. It's not curing them of a potential heart attack, but it is essentially giving them some pain relief and giving their heart some more oxygen. So when we give it, the heart feels a little bit better. Now, so again, this is not within your scope of practice. You're not going to be able to assist somebody with nitroglycerin, but it is if you are at an EMT level. So not particularly, because the clot is like really bound on to the wall of the artery. It's going to depend on if it's like a blood clot or if it's plaque buildup. But most of the time, what happens is it gets lodged and it sticks on and it binds itself to the wall of the artery. So making it bigger, it's not really going to move the clot. It's just going to allow blood around the side. Nitro doesn't affect clots very much. You can remove a clot by surgery. So it's one of those things, it's really tricky. They do have some pretty ingenious and really cool ways to remove clots. Essentially, they can feed like microscopic, like robots, essentially, little tiny cameras with little tiny hands on them into these arteries. It is potentially able to like pull out a clot. However, if you've ever heard of like a bypass, like a heart bypass, oftentimes if it's truly clogged, they can't remove it. Instead, they just kind of put a little shunt around the clot, so blood just goes in a different vessel around the blockage. So that section of their vessel is just, not useful anymore. They just create a new little, passageway around it. So that's all going to be stuff that like we're not really able to do. They need to go to the hospital for surgery. They need to go to the cath lab. The catheter lab goes in and removes things. They could also have what we call stents put in, which are essentially little tiny springs kind of that inflate. They get bigger and it just essentially opens up the vessel around a clot. So there are a lot of like Band-Aid patches, and it really depends on how big, what's causing it, all that kind of stuff to see if they could actually remove it. Now, one of the things that I find interesting about nitro is that it's also the main ingredient in dynamite. This is a blood pressure medication that we carry that is dynamite. It was used to create dynamite. The guy who discovered it, like in the 1800s, early 1900s, I think, essentially found out by accident because he accidentally ate some of his dynamite and he had a headache and he started to feel a lot better. And so then they looked into it a little bit and they're like, oh, wow, it actually opens up blood vessels. So, hey, now we use it as medication. But that's why we can't have any open flames in our ambulance, because we have oxygen and essentially little tiny pieces of dynamite. So let's keep that in mind. It's kind of interesting. Blood clots, where are blood clots most common? If you want my straight up answer, blood clots are most common on the outside of wounds, because you are creating a blood clot that's essentially a scab. You're clotting your blood to stop bleeding. However, if you're more concerned about what's going on inside the body, the most common like emergencies that we see, blood clots in the heart, in the lungs, and in the brain. A blood clot in the heart causes a heart attack. A blood clot in the brain causes a stroke. And a blood clot in the lungs causes what we call a pulmonary embolism. Blood clots can form anywhere. They're more common after like surgeries or broken bones. Honestly, they're a little bit more common if you spend like a long time in an airplane, sitting and not moving for a while in like the pressurized cabin. Sometimes what we call like deep vein thromboses. It's one of those kind of recognizable emergencies where somebody essentially gets off the plane, they have a little bit of leg pain, it kind of hurts, they're not entirely sure why, and then a few hours later they start to have either difficulty breathing, stroke-like symptoms, or a heart attack because a clot that formed in their leg breaks off, circulates through their body, and gets stuck somewhere else. So really, blood clots can happen anywhere where blood is, but it's more common after injuries, surgeries, and things like that. So another term, the lung clot is called a pulmonary embolism, or a PE. So another just overarching term I want to introduce to you is the idea of hypoxia. This is a term for having a general lack of oxygen. So this is a condition that can be caused by a bunch of different things, like asthma or pneumonia or like a COVID even, where they're just not able to get oxygen into their body. And this can actually cause a big issue, where people who do not have enough oxygen are typically really grumpy, right? Somebody who's not getting what they need tends to be aggressive, like agitated, really short-tempered. And so that's a sign that we need to be looking to see how much oxygen they have. One of the things we say is nobody on an ambulance, no patient on an ambulance is a jerk until we've ruled out that they have good blood sugar, enough oxygen, and they don't have a head injury. After that, if they're being a jerk, they're just a jerk. But if they have low oxygen and they're being mean, you can't blame them, all right? Because their brain is not getting the oxygen that it needs. So this is a sign of hypoxia. So another thing you might see is that cyanosis, like a blue tinge to their fingernail beds, their gums, their lips, or their tongue. And that would just be like, ooh, they are not getting enough oxygen. I need to call an EMT to make sure that we can get some oxygen delivered to them. Now, another life-threatening condition that is a little bit of a circulation and a respiration issue is what we call anaphylaxis. So allergic reaction, right? You don't have to self-identify if you don't want, but does anyone here have an EpiPen, like an allergic reaction, anaphylaxis? Yeah, I see some hands raising, right? Well, that's essentially what's going on here, is your body kind of over-responds to an allergen. So allergies are on this big spectrum. Like, you could get sniffly or itchy eyes during like the springtime when all the pollen is out. You could have like gastrointestinal distress if you drink milk or eat something that you're not, you can't really process very well. But anaphylaxis is essentially a body-wide issue. So your body over-responds to this allergen. It opens up all your blood vessels, and that fluid starts to pool in certain areas. Sometimes it can be in just the general area. Like I had a friend in elementary school who was allergic to bees. I remember him getting stung, and he came back in from recess and his whole hand looked like a balloon. It was like super swollen. He wasn't having any difficulty breathing stuff, but that was bad, right? It got really swollen. So we start to get really worried about this swelling, about this anaphylactic reaction when it starts to swell in somebody's face or their mouth, because their tongue and their airway can also swell up. So similar to like choking, right? Where somebody has a blockage in their airway. This swelling can actually get so bad that it closes off their airway on its own, making it so they can't breathe because their body is essentially swelling shut. Now, that is a life threat, right? Anaphylaxis is another type of shock because their body is not perfusing, it's not circulating well enough. So the signs of it are new hives, like these types of, bumps forming on someone's skin, kind of looks like a rash. Also what we call angioedema, which is just swelling in the face, in the mouth. And it can also swell the tongue and swell the airway, and it also can make the lungs close up. So all of it is bad, right? We do not want someone to be in anaphylaxis. This is a life-threatening injury that we need to essentially treat right away. Now, the good news is there is a medication that we can give that essentially reverses it pretty quickly. Hey, life-saving slide, come up. This is a sign for you to pay attention because I'm about to tell you about a medication that's within your scope of practice. Okay? Now, when we talk about medications, these are things that you do have to memorize, all right? You need to know the reasons we would give a medication, called the indications, the reasons we would not give it, even if we wanted to, how much we're going to give, how we get it into the body, what it does to the body, and if there are any side effects. For every medication that you are going to be given responsibility for, you do need to have all of these pieces of information memorized, all right? So, epinephrine, or an EpiPen. This is what we are going to give somebody in the event of anaphylaxis, right? Does anyone know another name for epinephrine? I have said it earlier today. Yeah, Zoe, Evie, Ben, absolutely. Adrenaline. This is a naturally produced chemical inside our body. It's what makes us have that sympathetic nervous system response, right? The agitation, the fight or flight. But we need to be able to give it to somebody who's having an allergic reaction, so we essentially give them an artificial adrenaline rush. Because what does that adrenaline do? It makes the vessels clamp down, it increases blood pressure, it opens up the lungs. So if somebody's having an anaphylactic reaction and you give them an EpiPen, they will essentially have those symptoms reversed very quickly because epinephrine does the exact opposite of what an anaphylactic reaction is doing. So we also are giving what we call epinephrine 1 to 1,000. This is a very highly concentrated version of epi, which means it's only going to go into certain parts of somebody's body. We don't want to give it in a vein because that could actually hurt their heart. So that's why we use these injections like an EpiPen. Now, the only reason we would not give somebody epinephrine in the event of anaphylaxis is if they are not in anaphylaxis, if the medication is expired, or if you look in this little window right here, you can see the medication and if it looks like moldy or gross, right? The other contraindication is we can only give that person their own prescribed EpiPen. So we can't just give them any old EpiPen. So if somebody is having an allergic reaction, they don't have their EpiPen on them, but some rando comes over and is like, hey, I have an EpiPen too, you can give them this. No, we can't do that because it's not their prescribed medication. What we'll need is we'll need an ambulance on the way who carries Epi in little vials for which we can give to them. Now, the dose of how much medication we're going to give them is dependent on the patient. This is why we don't want to be just taking anybody's EpiPen and delivering it to them, because there is a specific amount of Epi that that person might need to receive. So for an adult, we give a dose of 0.3 milligrams. And then for a kid, a pediatric, we give half of that, 0.15. You guys as VEFRs, you're only going to be able to assist with EpiPens, and those will be pre-dosed. There's an adult version and a pediatric version of the EpiPen, so you don't really have to worry about like drawing Epi out of a vial. You can just make sure that it's their EpiPen and give it to them. But we don't want to be giving a pediatric patient an adult dose, and we don't want to be giving an adult a pediatric dose, because either we're giving them too much and it could lead to other issues, or we're not giving them enough and it's not going to fix their anaphylaxis. So the route of Epi is intramuscular, into a muscle. So the preferred site is the lateral thigh, the outside of the thigh, like by a pocket, right? And so that is just a large muscle, and we inject it through there. That's very easy to do. So typically it's based on both age and weight. Essentially how we do it as advanced EMTs, because I can draw up an Epi dose and give it without an EpiPen, is I would go based off of weight if they didn't have their own Epi. So essentially, but it's less likely, I'm not going to be drawing up a different amount of Epi based off of their weight. It's like if they're under 55 kilograms, I will give them 15 or 0.15. If they're over 55, I'm going to give them the adult dose. So it's a little bit of both, if that makes sense, Zoe. Now, I described the actions a little bit earlier, but these are the medical terms for them. The actions are, it is a vasoconstrictor. It makes our blood vessels, our veins, and our arteries get smaller, constrict. And a bronchodilator. Does anyone want to try to guess what a bronchodilator means? Exactly, Zoe. It dilates the bronchi. So those tubes inside the lungs that we have, the bronchioles, right? They are constricting, they are getting tight because of the anaphylaxis. And if we give them a bronchodilator, it causes them to open up. So epinephrine makes blood vessels smaller, and it opens up the lungs, reducing that swelling and making it easier for them to breathe, right? Now, side effects of Epi are essentially the side effects of an adrenaline rush. If you've ever had an adrenaline rush, your heart is beating really fast. You also might be like tremoring a little bit, be a little shaky. And you could also feel pretty anxious. So these are very common side effects after delivering Epi. But the good news is, if you know that these are normal side effects, if your patient is like, hey, I feel like I can breathe better, but I'm really shaky, my heart's beating a mile a minute, and I feel really anxious, you can be like, hey, everything's fine. This is actually a good sign. This tells me the medication is working, right? I just gave you an adrenaline rush in a pen. I would be very alarmed if you weren't feeling a little bit agitated. So just try to take some nice deep breaths, and it will feel better, okay? So knowing the side effects are very important as well. Now, the other thing to note about an EpiPen is it is not one and done. You can't just give somebody an EpiPen and be like, okay, cool, you're all set. You don't need to go to the hospital. You're good. Because epinephrine only lasts about 15 minutes in someone's body, and anaphylactic reactions can last up to hours, okay? So an EpiPen is one of those things that we give to keep them alive long enough for an ambulance to arrive and then bring them to the hospital, right? Where they can get more Epi. That's why we want to be calling 911 if we haven't already, or if we're not responding. If we're just assisting somebody with their EpiPen, make sure that 911 is called before you do that, so that the ambulance is already on the way. That's going to be really important, okay? Because they might need more epi on the way to the hospital. Unfortunately, it has happened quite a bit where people who do not know about this, they have an anaphylactic reaction, their friend gives them their EpiPen, they feel a lot better, and they're like, oh, okay, yeah, no, I'm good now, I don't need to go to the hospital, and then they essentially go home, they go back into anaphylaxis, they've used their EpiPen, they don't have another one, and now they're alone, and it's a lot more scary and worse, okay? How much epi can a person have in a span of 24 hours? I don't have a direct number for you. In my protocols, essentially, they can have a dose of epi every 15 minutes as long as symptoms persist. So for an EMT, I'm not likely to be with a patient for 24 hours, but I do know that up at the hospital, if someone's having like a really severe anaphylactic reaction, sometimes they put them on what we call like a drip of epi, where they have a bag of saline, they put the needle in the arm, they put a little bit of epi in there, so they're getting like a constant amount. So I really don't think there's a huge end limit. It's really based on their symptoms. Like if they're still having anaphylactic symptoms, every 15 minutes they're going to get a dose of epi until that allergen leaves their body. So great question, Evie. Now, EpiPens themselves can be dangerous if we don't use them correctly. Okay? I would teach you how to safely handle an EpiPen in a very similar way that I would teach you how to safely handle a firearm. There is a safety, there is a trigger, and there is a projectile that you do not want to be in the way of if you're using it incorrectly. And now I'm going to show you a video. This is also a time that I like to personally thank you guys, because I'm constantly looking for videos for EMT classes and VEFR classes that like demonstrate, an emergency or somebody doing something wrong. And majority of the videos that I will show you are recorded by high schoolers and posted to TikTok. So thank you very much. Let's watch this video. You're going to watch this girl demonstrate to her friend how to use an EpiPen correctly, maybe? Ooh. So, that went through her thumb. You guys ever watch like a nature documentary and David Attenborough is like, this frog is this orange color because it is incredibly deadly. It is a warning sign to other animals not to touch it or you will die, right? It's that same color. That is not a button for you to push with your finger. That is a button to push against somebody because the needle comes out of there. The needle is probably, I don't know if you can tell from this, but it's probably about that long, because it needs to go into muscle pretty deep through clothes, and it comes out at like 200 miles an hour. It's like a sneeze. So good news for this girl. It went through her thumb, and she probably didn't get any epinephrine into her body. So she probably didn't have any reactions from it. But that needle went through her thumb, okay? They're still treating her just in case, but she's fine, right? But that's one of those things. You need to be very careful, because if you were to do that, instead of give a person an anaphylaxis epinephrine, you have just wasted the life-saving medication and you've just hurt yourself, okay? So, I don't have a fake one with me here, but let's go back to this. Blue to the sky. Orange to the thigh, right? You're going to take that EpiPen, you're going to leave that blue safety on, you're going to line it up against the side of the thigh, you're going to remove the safety, and then you're going to click the pen down. It will make a click sound when you push it hard enough. And you're going to hold it there for 5 to 10 seconds so that the medication can be injected, okay? When you remove it from the person's leg, that orange cap will come out further to protect, to like stop anybody from accidentally pricking themselves on the needle, but do not throw away the EpiPen, okay? You need to hold on to it because an EMT is going to want to check to make sure that it was injected correctly. So, Zoe, no. The dose of epi for anaphylaxis is not the same for restarting a heart. When we're doing cardiac arrest work, you noticed back here, we give 1 to 1,000 concentration epi. For cardiac arrest at an advanced EMT level, we give 1 to 10,000 concentration. So it is a much more diluted version. Because if we put really concentrated epi into someone's veins, it can damage and like make their heart stop even more. It can really wreak some havoc on their internal system. So we essentially give them a much more watered down version of epi, and it's probably around the same dose, but it's just a higher milligram concentration of fluid. Side effects of accidentally taking epi or dosing too much. So that would be a difference, right? If we accidentally took a EpiPen as an adult, it probably wouldn't kill you, right? You would probably just have a very strong response to it. You would have really fast heartbeat. You would be breathing really quickly. You would probably be pretty anxious and tremory. But if you take too much, that's going to lead to just like cardiac arrest because your heart is going to beat too fast and it's not going to be able to circulate blood. So it is not a good thing, right? You definitely don't want to do that, okay? Allie, what is the difference between antihistamines like Benadryl and epinephrine and the intensity? So they're completely different medications. Antihistamines, essentially, histamines are like released when somebody's having an allergic reaction. So that Benadryl medication suppresses those histamines that come up that start to present as like swelling, itchiness, difficulty breathing. And it's not like a life-saving medication, but it does prolong some of those symptoms, right? So like somebody who's in anaphylaxis doesn't need Benadryl. They need epinephrine, and then they can take Benadryl after that to help suppress some of those symptoms. So epi is what we call like a hormone. Actually, it's naturally produced in our body. It's adrenaline, whereas Benadryl is a medication designed to help suppress some of those histamines that come up in these allergic reactions. Great questions, everybody. I won't make you watch this again. Okay, we're getting close to the end here, guys. So suctioning. This is something that we might need to do in order to remove fluids from somebody's airway. Now, it could be with like a manual suction device like this. They don't work that great. They're kind of annoying, but these were the first things that we had before we started, using like powered suction ones. There's also just a powered suction device in an ambulance. So that's typically what we use. But if somebody has fluid like blood or vomit or really anything in their mouth that is blocking their airway, we're going to want to suction it out because that becomes an airway obstruction, right? Now, we also need to wear a lot of protective gear. So gloves, goggles, potentially a face mask when we do this, because when we suction, we are actually like spreading particulates of whatever's coming out of them into the air, right? And we don't want to get that in our eyes, ears, nose, or mouth. And it's pretty gross. We don't want to catch a disease or anything like that. The correct time to begin suctioning a patient's airway is as soon as you see that it is clogged with something. So one of the first things that we do, we're going to teach you about like assessing the ABCs. Getting down, opening their airway is one of the first things that we do if they're unconscious. And if we see anything in there, the first step is to suction that airway out, because an airway blockage is a life threat, right? A, B, and C, we want to fix any issues with that. So if we can clear out the gross stuff in their airway, they can hopefully start breathing again. Now, I just wanted to show you a video too, because there is a level of, difference in how an EMT and a VEFR might treat somebody with an airway issue. So at the EMT level, you can start putting in things that we call airways. So it's essentially like a little device that will insert either into somebody's nose or into their mouth, which is going to help keep their airway open so that we can help breathe for them. So this is called a nasal pharyngeal airway. Now, if you don't recognize that guy, that was me. That was when I first got my EMT license, and my friends and I were talking, and I was like, oh, I haven't put in a nasal airway on a patient yet. And he's like, oh, I haven't either. And I was like, hey, I'll let you do it to me if you let me do it to you. And he put it into my nose. What you didn't see is right after that video ended, he got a call. He was on duty. I wasn't. And he had to put a nasal airway in, like right after he did that to me. And I didn't do it for another couple of weeks. I did it because I wanted to see what it felt like, because I'm going to be doing it to patients, right? that isn't something that's like what we call super invasive. It wasn't like I was doing an IV on myself or giving myself medications. I just wanted to know what it felt like. It's not very pleasant, but what it does is it creates a solid or a more stable tube through which we can provide air and oxygen down to somebody's lungs, right? If they had a blockage in their airway, like I couldn't get oxygen down through their mouth very well. If I put one of these tubes in, it's essentially going to help me get air directly down through their nasal passage towards their lungs. So after an EMT course, you would be allowed to do that. That is part of an EMT skill. You could do a nasal or a oral pharyngeal airway. Won't make you watch it again. Now, another skill that we're going to practice at the Institute is mouth-to-mask ventilations. Now, you may have been told about things like mouth-to-mouth resuscitation. We actually don't do that anymore. The only time we would do mouth-to-mouth is if we know the person well enough to feel comfortable to kiss them, and also that we know they weren't put into difficulty breathing based off of like a respiratory illness, right? If you are doing mouth-to-mouth on somebody who was put into cardiac arrest due to COVID, or another communicable disease, you are essentially guaranteeing yourself that you're going to catch that, and you could also go into a very serious situation too. So the only time we do anything like that is with a mouth-to-mask ventilation, and you can see here that there is a big filter attached to this mask, which blocks like bacteria and viruses. So we're going to practice how to do this at the Institute, because if you arrive and somebody isn't breathing, you can absolutely have one of these pocket masks and breathe for them. So that's part of your skills, part of your scope of practice as a VEFR. And I can't really do much online to teach you about this, but essentially you're going to do a head tilt chin lift or a jaw thrust. You're going to create a good seal with the mask on their face, and then you're going to breathe into the mask until you see their chest rise and fall. And that's basically it. So at the Institute, we'll get a good amount of time to practice doing that. And that's it for today. So same time tomorrow, 11 o'clock. I will be again in the Zoom room starting at around 10:30. Those of you who came earlier, I just listened to music, get prep for the class. It's also a time that you can come in and like ask questions if you had anything you were interested in. Tomorrow is a very interesting day as well. We're going to talk about patient assessments. We're also going to go over like the medical legal aspects of being an EMT and VEFR. We're going to talk about some neurological injuries, and we're also going to talk about opiates and overdoses. So now I'm speaking to you, who is potentially not here in the Zoom room right now. You're watching this on the recording. You need to fill out this exit ticket to get credit if you were not here. And then anybody here in the Zoom room, just go ahead and test yourself if you would like by going to this exit ticket. I was reviewing some of your answers from yesterday's exit ticket, and you guys were doing a pretty good job. The one thing I wanted to clear up that I think most people who got a question wrong got it wrong was that the VEFR certification is the governing body that administers the VEFR certification is the state of Vermont, not the National Registry of EMTs. The VEFR certification is a Vermont only cert. So everybody did a really good job on those. Just wanted to clarify that. But otherwise, I'll just be sending out the recording to this and everybody in a little bit. So go forth and have a great day. I will see you tomorrow. You're welcome. Bye, everybody. Great to see you. Take care.